लाइव स्टार्ट करें.
So good morning to everyone. So today is the last day of our Raabta 2025. I would like to extend the warm greetings to all of you for our this Raabta 2025, which is a aesthetic meet. And this time, previously there was also 2 meets, which was only confined to 1 day, but this has been extended for extra 2 days. So thank you very much for all your cooperation. And yesterday night, all have enjoyed, and we are really happy to have you all here. Thank you very much for your excellent cooperation and all. So we would like to start our session. So please be ready, speakers be ready, and please get into the seats.
A very good morning to all. Without further ado, we begin today's session. I would like to invite Professor Vijay Kumar sir, Dr. P.V. Sudhakar sir, Medha Bhavi ma'am, and Dr. Ramesh Das sir to chair today's session. For the first talk, I invite Dr. Kshitij Gupta sir, who will be talking about application of microneedling radiofrequency for scar treatments.
सर के पास होगा ना पीछे से हो जाएगा. देखो है नहीं आपका.
सर ये कल वाले जो पेंडिंग थे वो हैं.
So Dr. Kshitij will be presenting application of microneedling radiofrequency for scar treatment. Dr. Kshitij.
Yes, sir.
You can
Sir,
start.
actually, the connector is not working. Rathore sir is getting a connector for us, so we'll just wait for 2 minutes. Connector है? नहीं? सर हो गया. Good morning, dignitaries and my dear friends and my dear colleagues. Today we are going to talk about application of microneedling radiofrequency in the management of scars. So I am Dr. Kshitij Gupta from Jammu. So no conflicts of interest, though there is no support or commercial funding for this presentation or for any products mentioned here. Scars, as we say, is an area of fibrous tissue that replaces normal skin after injury. Scar tissue is made primarily of a protein called collagen. Scars may appear flat, sunken, lumpy, or colored. So briefly about the type of scars, atrophic scars, hypertrophic scars, keloid, contracture scars, stretch marks, and flat scars. So scars do have an impact on one's life in the form of the patient may turn up with aesthetic concerns, psychological distress and loss of confidence, and functional limitations as well. So we do have, as plastic surgeons, we have conventional scar treatments, which include use of topical agents in the form of silicone gels, retinoids, laser resurfacing with laser dermabrasion, chemical peels, intralesional injection, and surgical in the form of scar revision. But all these conventional methods do have limitations in the form of variable results, higher downtime, and risk of pigmented changes in the form of PIH. So today, I'll talk about microneedling radiofrequency. Microneedling radiofrequency is expected to overcome the limitations of all these conventional scar treatments. So with evolution, it has been a popular procedure performed nowadays in India. So what exactly microneedling is? It is basically a minimal invasive, non-ablative system which delivers both monopolar as well as bipolar radiofrequency energy. So how exactly it works? It basically, it combines microneedling, mechanical microinjury which is delivered with the microneedles with thermal energy which is in the form of radiofrequency, and it directly targets the dermis without affecting the epidermis. So thereby promoting neocollagenesis and neoelastogenesis. So briefly, what exactly is radiofrequency? It utilizes intrinsic resistance of the tissue to convert electric current to thermal form. So thereby this thermal energy, it gives a targeted depth, mechanically contracts dermal collagen fibers and results in improved delayed biochemical remodeling and neocollagenesis. So why we are now going towards radiofrequency? Because of the lesser downtime and almost near nil epidermal damage. So evolution of radiofrequency is quite interesting. So initially it was the traditional radiofrequency microneedling. The non-insulated pins were used. The depth was only up to 3 mm. So with the evolution, it got upgraded, and nowadays we call it, the devices are subdermal adipose remodeling devices. So nowadays the newer devices have insulated pins. We can go up to 3 to 4 mm on the face and up to 7 mm on the body. And mechanism of action, basically the microneedles, they penetrate the skin. So the depth may vary depending upon the treatment site, the location, the indication, and the type of the scar. So depending upon the indication, we have to adjust the depth of the depth of the needles. That can vary from anywhere between 0.5 to up to 7 mm. So radiofrequency is directly delivered to the dermis. So there is a controlled thermal damage which stimulates wound healing, and thereby, there is neocollagenesis, collagen remodeling, and skin tightening as well. So as we can see in the picture, so the micro injury and radiofrequency, it stimulates the collagen production, and new collagen, it improves the skin elasticity and firmness. So this is basically an advanced, superior, and diverse procedure. A broad spectrum dermal heating is totally closed loop. As we can see in the picture, there are 3 zones of thermal injury which actually occurs. So the innermost zone is ablation, followed by coagulation and non-specific heating. I would briefly tell you about the devices which are available nowadays. They are monopolar devices, bipolar, and fractional. As we can see, monopolar is basically used when greater depth of the penetration and higher volumetric heating is desired, which is basically used in cases of body contouring and fat dissolution. And bipolar is nowadays necessarily used when treating facial acne scars or some superficial scars. In my practice, I have been using microneedling for almost 3 to 4 years now, and I have been using quite frequently in cases of acne scars, post-surgical scars, stretch marks, and post-traumatic scars as well. So I have my own protocol. So once the patient comes, first of all, obviously we'll have to explain to the patient, we have to assess the scar type, the location, site, and the type of the treatment which is required. And if we finalize, and if after assessment, I feel that the patient is going to get a better result with microneedling, and the patient has some other concerns, so microneedling is finalized. And once the procedure is finalized, we take a pre-procedure consent. This is followed by the use of topical anesthesia, which is basically, I use it, a combination of lignocaine with prilocaine, and we keep it for 40 to 45 minutes. So once the topical anesthesia time is over, I thoroughly clean it with normal saline, and maybe we can use an antiseptic solution as well. And on the basis of the site, location, and the type of the scar, we decide the depth for which the microneedles have to be penetrated, how much energy is to be kept, and how many passes are required. And in the procedure, post-procedure care is very important. Nicely, you have to clean the face with, I actually clean it with normal saline. If there is some pinpoint bleeding, I'll use an ice pack or maybe some, cool normal saline. Patient is advised, and this is followed by a use of a topical antibiotic with or without a mild steroid. Patient is advised to use sunscreen strictly after the procedure for at least a week and maybe after that as well. And patient is advised to strictly avoid sun and heat exposure. So what I see with each sitting, probably after second or third sitting, I've seen quite good results. So there is significant improvement in the depth of the scar, the texture of the scar improves, and there is improvement in the pigmentation. And overall studies, if we say the available studies, overall studies available online, still now there are quite less studies, but then the studies which are available, they've shown that there is significant improvement, which is more than almost like 50% improvement in scars in just 3 to 4 sessions or up to 5 sessions. And long-term collagen remodeling still continues after the treatment is also over and for a period of over 3 to 6 months. Why we have been following this? Because there are good benefits of microneedling. It is basically minimal invasive. It has a minimal downtime. The patient can get a procedure done one evening and resume all his or her activities on the next day. And I probably, if a patient has like working in a place where there is more of heat exposure or sun exposure, I usually advise all my patients to usually get it done on Friday evening or something and take rest on Saturday, Sunday, and then resume their activities on Monday. And there is reduction in the scar appearance, the texture improves, and overall skin tone improves. It is safe for most skin types. The delivery of the radiofrequency is very nice. The precision is very good. And if we compare with the ablative lasers, the risk of PIH is quite less. But yes, all procedures, as we say, they have some limitations and side effects as well. There is mild erythema which may stay for 1 to 2 days. The swelling might be is seen. Some patients may complain of mild discomfort and pinpoint bleeding, which is easily managed immediately after the procedure. And yes, if we are using some aggressive settings, the depth is high, energy is high, then we might see PIH, which may stay for 7 to 10 days. And the multiple sessions are also required herewith. So as I can show in the picture, so this is my post-traumatic case. This is the result after 4 sessions. And this is the case of acne scars. The result is quite good in just 3 scans. The patient is 54 years old male, having acne till now at this age as well. So he's a businessman, but there is an improvement in the acne scars. He's still taking treatment. And this is a post-surgical scar result, quite good result after 2 sessions. And then stretch marks also have seen good results after 3 sessions. And this is again another case of the acne scars, significant improvement after 5 sessions. So now I would like to conclude that microneedling radiofrequency is a versatile, well-tolerated and effective minimal invasive tool for scar management. It is safe and suitable for most skin types. It offers significant improvement with minimal side effects. And it can be used as a standalone procedure, but yes, it's always best to combine it with other modalities like some topical agents or maybe some surgical procedures for better superior results. Till now, as we can see, there's still few studies evaluating the efficacy of these insulated fractional microneedling radiofrequency devices in the treatment of scars, and still a dearth of scientific data and literature on the optimum techniques and the results can be obtained. So still now the studies are on. Obviously, we have been using them quite frequently nowadays. So I would say that there's still a void which has to improve, which has to be filled up nicely in the time to come. And thank you so much. And with this, I would like to invite you all for AE Search 2026 under the esteemed leadership of Dr. Medha Bhave ma'am in the month of January in Mumbai. Please do register yourself for the meeting as early bird is closing soon.
Any questions or comments?
I want to ask, MNRF is generally said to be color blind. So how many PIH you have encountered? And second,
Yes, sir.
MNRF is generally said to be color blind.
Yes,
That means you can do for the skin Petris type even up to 7 also,
Yes, sir.
6, 7. And have you encountered PIH? And secondly, do you routinely prescribe steroid creams following MNRF?
Sir, yes. So I have a personal experience with my wife directly. So when we got the machine, so it was like she volunteered for the session, and what happened was, like, initially we were not sure about the depth which has to be used. So I think I was a bit aggressive on the needles, and I think the depth was more. And as a doctor, she's also a doctor, so she's a gynecologist. So she told me that she's not going to apply any cream on the face and she'll be fine. So immediately after the procedure, her face was totally fine. But next day, there was PIS, there was a lot of swelling. It was as if I have slapped her on her face. So, so that was one day. And then, you know, when PIS settles up and then there is inflammation and edema and erythema. So after it has set in for the next, like after 12 hours or something, even if you apply good creams or something, it is going to take its own 5 to 7 days time. So what we did was, after that, I decided a protocol. So normally I use in all my patients a combination of something like a mild steroid in the form of mometasone, or maybe with fusidic acid. I prefer using that.
Okay, that means you are routinely using steroids.
Sir, but I have tried using it only with a normal fusibate as well. But I would say that the anti-inflammatory part is quite good, and the patient is more comfortable, not complaining of pain after the procedure.
But at one point you want inflammation, so that there is an improvement.
Exactly. We want inflammation there, so we should not cool
Not use
even
it.
for little bit of bleeding. Just
Maybe I encountered with one odd case personally at home. Maybe that's why I'm over-conscious, because wife didn't say anything. But if that would have happened with some patient, that patient would have come and sit in my clinic and had taken my life away.
what I want to ask you is whether you combine it sometimes with PRP,
Yes, ma'am.
nanofat. What is your experience in that?
Ma'am, I have used it with PRP. The results are outstanding, obviously, because you with the help of microneedling, you make the channels, and then PRP, and as well as nowadays, I have thoroughly discussed with Radho sir that I have tried using exosomes as well. So it makes the channels nicely, and then, you know, the PRP fluid or maybe the exosomes can be nicely delivered to the deeper layers of the skin.
The downtime get decreased and the
Yes,
chances of
and the
PIH
recovery
also get
is
reduced.
very good. Yes.
Second question,
Yes.
Your needles are insulated or non-insulated?
So insulated.
If they insulated, then the epidermal burn will be less,
Yes,
then
sir.
less chance of PIH.
Yes, sir. That's right.
Ma'am, what do you say, ma'am? You are using it quite a lot, ma'am.
Yes, actually PIH is a product of heating. So how much heat you use, that will decide the PIH. And obviously if you are ablating the epidermis, then the wound is going to heal, and that may result in PIH as well, depends
ma'am.
on the patient's tendency.
That's right.
Thank you.
Sir, normally my protocol is to keep a gap of 1 month in between the sessions. So normally I tell all my patients to keep a gap of 4 to 6 weeks in between the sessions. So average protocol is exactly 1 month, but I'm a bit flexible about 1 week up or down, something like that. But minimum. Sir, see, collagen synthesis and elastin synthesis takes around 21 to 28 days. So So it's better to give a gap so that in between the sessions the recovery is good and patient will see significant improvement.
So I have two things. One,
Yes,
the
sir.
mometasone you are using, actually it reduces the redness of the skin. It's good.
Yes, sir.
Because whatever the inflammation you want, that is underneath the skin.
Yes, sir.
Okay, not on the skin. Second thing is there is a school of thought. It reduces volume because of the fat loss effect. So what
sir.
is your take on it?
So the second question.
It reduces the volume underneath the skin because it melts fat. Like MNRF, it has thought that it melts fat to
It
some
reduces
extent.
fat.
It reduces fat.
Okay.
So what is your take on it?
Frankly, I don't have any experience on that.
Madam,
Very nice.
Actually,
madam.
on the face, maximum penetration is 3 mm.
3 mm.
Right.
Yes.
So it will just reach the SMAS. It will not in MNRF. But if you are using face tight, which you put inside, that will definitely melt the fat. And I will always combine any face tight with fat grafting.
Right.
But for Morpheus,
Yes, Morpheus,
that is
right.
micro needling,
Yes, yes.
it is generally up to the SMAS, not deeper than that, but still in the neck especially, because the neck skin is thin, the subcutaneous fat melts and that make give a wrinkly effect to the neck. So even in neck, I like to stay superficial and in rejuvenation mode
Yes.
rather than fixed mode which melts the
Yes,
fat.
because there is
Yeah.
you have a parameter to control the
Yes,
depth. You
yes.
can up to go up to 4 millimeter, and you need volume on the cheek. So
Yes,
that area also
yes.
you need
No,
less
otherwise,
penetration.
it is best to put it under local. Also, you can take out 15-20 ml fat and put it in the malar fat pad.
Right, ma'am, it is the depth which is most important. If you're targeting to burn the fat, then you have to reach subdermal or more, then 3 or more mm. Otherwise, confined to a 2 mm
2
only.
mm and low energy.
Low energy.
Thank you, Kshitij.
Yes. Thank you so much. Thank you.
Now, nice presentation, nice discussion.
Thank you so much. Thank
Now
you.
I
Thank
call upon Dr. Itishri Gupta, civilly presenting on therapeutic evolution of minoxidil from topical therapy to oral.
Hi, good morning, everyone. Morning, chairpersons. Thank you for inviting me as a faculty to present this topic. And so I'll be talking about the therapeutic evolution of oral minoxidil. Basically, minoxidil has been, minoxidil has been used as a topical therapy for many years. And now we have also started using it as an oral therapy. So I'll just be discussing what is the reasons we have shifted to oral therapy and why we use it as a combination also. So minoxidil was first used as an oral drug, as we all know, to treat refractory hypertension. And we discovered while it was used that there were cases of, developing of hair as a side effect. And that property was exploited and this drug came into use. So initially it came into use for a topical application. In 1970, it was used as a treatment for refractory hypertension. And basically, it has a relaxing effect on the vascular smooth muscle through which it acts. So it doesn't act as a dihydrotestosterone thing like a finasteride. It basically acts through the relaxing effect. That is what causes the vasodilation and the hair growth properties of minoxidil. So in the natural evolution, now minoxidil, as I said, was started in the 1970s. And in 1988, a topical 5% solution was used, the alcohol-based solution. Later, a foam preparation was also used in 2006. And initially, it was only used for male pattern baldness. Then after that, in 2014, it was also started for female pattern baldness or hair loss that was there. Now it has been used, so it has not been approved by the FDA yet, but an off-label use has been started with low-dose minoxidil. Low dose means it is less than 5 milligram. So what is the need, like why oral minoxidil came into place? Basically, there is an unmet need and there is a variability. So what happens is minoxidil, that is the topical preparation, it needs to be converted into its active metabolite by the enzyme sulfotransferase. Now, so because it needs to be converted into its active metabolite, it is dependent on the presence and the quantity of the sulfotransferase enzyme in the hair follicles for its action. So this leads to variability in the effect of minoxidil when it is applied over the scalp. The other thing is the adverse drug reactions. So a lot of irritation due to the alcohol component leads to less compliance because it causes itchiness, it causes irritation, it also causes a little bit of greasiness. If you've used topical minoxidil yourself or had patients, they always complain that it feels very greasy and sticky and they're not very comfortable applying it and going to office or work. So quite often they do not use it twice daily, which is recommended, and they end up skipping the morning part and only use it at night. Also, they're not very comfortable styling their hair because they say that, so obviously we want good hair so that we can style it and, you know, have a silky appearance. Even guys keep a lot of long hair these days, so they want to be able to style it. Using minoxidil kind of, you know, prohibits them from being able to style it freely. So a lot of people don't want to use it twice daily. So compliance reduces. When compliance reduces, obviously the effect will reduce. A lot of people use it for a few months and then, you know, stop using it. So it causes a lot of rebound hair fall also because of that. Now, as I've already mentioned, that this causes a variation of the effect on the hair. These are the adverse drug reactions. Sometimes it can cause some allergic dermatitis also due to the constant irritation. And now, as I said, the compliance, twice daily application, very difficult, which is why we needed to explore something that could supplement the action. So now I'll just discuss, there are a lot of studies that have been done. Just going to run through the studies, I won't bore you too much on this. So as you can see in this, oral minoxidil shows promising effects in hair loss, especially, so there is a very low dose which is less than 1. Then there is a low dose and there is a normal regular dose of minoxidil that is there. So less than 5 milligram per day is what we use, but effectivity is better when it is more than 1 milligram per day at least. So we start with lower doses in females initially, a little higher in males. I'll just be discussing that. So this is again a comparative efficacy of minoxidil and 5-alpha reductase inhibitors monotherapy. So as you can see, the oral minoxidil and the topical ranked higher in terms of promoting hair growth. So oral minoxidil is a safe and successful treatment of both androgenetic alopecia and alopecia areata. Again, I'm just running through the studies because of short of time. So this you can see, this is a 12 months result. You can see the density has improved overall. In this, a combination treatment, as is usually done for all hair growth solutions, a combination treatment was used for the effect. So oral minoxidil is effective, but it is even more effective when it is used along with the topical minoxidil. So it potentiates the effect. Now, this is a positive dose-dependent efficacy of low dose. It shows that there is a change in hair diameter and hair density both, which leads to, so when you talk about hair growth, there is one about increasing the hair density, which causes the effect. Also, if the dense hair have a thicker diameter, they appear more dense because of more scalp coverage. Because the baldness is due to the reflection of the light on the scalp, and increasing the hair density and diameter both cause the reduction in the baldness, bald look that is there. Now, in this, you can see that it is effective and had an acceptable safety profile. All of these parameters were seen. And again, this is for the treatment of female pattern alopecia. Now, a 0.25 mg versus 1 mg was compared. As I've discussed that at least a 1 milligram is more effective, less than that is less efficacious. And this was a study at 24 weeks, the results were compared. Even late alopecia and cancer survivors, even topical minoxidil is effective, but oral minoxidil was seen as a very good effect. And as I mentioned, a concomitant treatment with both the oral and the topical was demonstrating a better response and a higher percentage of hair density per centimeter square from the baseline as compared to topical therapy alone. So it should always use in combination. And this is again, then there are clinical evidences on the safety in Yeah, so this is always a common question when you talk about oral minoxidil about the effect on blood pressure. So as it was a drug which was used in severe refractory hypertension, but the doses were much higher. So when you talk about normotensive patients, there is not a significant drop in blood pressure. However, in hypertensives, there may be some drop in blood pressure, so it should always be used with caution. And initially, we always advised a weekly or sometimes even a daily blood pressure monitoring to make sure that they're tolerating the drug well. We always start with low doses. So in females, you can start with either 0.625 or 1.25 mg per day and then gradually increase it over a period of 1 month or 3 months. In males, we can start with 1.25 milligram and then increase it to 2.5, eventually to 5 if required. So always we go gradually so that we make sure that side effect profile is okay. And then again, initially few months there may be some increase in heart rate, but in normotensives, the BP fluctuation is not that much. So, yeah. So administration of 5 milligram, which I mentioned, usually that is the maximum dose we use. And in normotensives produce very slight reduction in blood pressure. So yeah, so BP reduction is more in the first hours. It peaks in the first 2 hours after the drug intake. This drug also sometimes has issues of postural hypotension. So it is preferred as a oral dose in the morning, so that in case all of that is there, it is the peak is after 2 hours, and night they don't have any issues. It settles by then. So again, most of the people who, if at all, need to discontinue therapy, it is not due to hypertension, it is due to the hypertrichosis which might happen. So now considering this is an oral drug, it can produce increased hair growth in other parts of the body also. So usually for males, this is not a significant issue. However, for females, it can cause a problem. So we are starting with very low doses and increasing it. In case they experience hypertrichosis, we can stop the drug and the effects are completely reversible. Also, in patients who have PCOD or issues with hirsutism, we should avoid using the drug. So also one more point is that why FDA approval also hasn't been received yet. In mice, there were cases of some cardiotoxicity, pericardial effusion, etc. That is at much higher doses. However, in cardiac patients with history of previous cardiac diseases or old patients, we should be very careful and cautious and preferably avoid this drug in those patients. However, with caution, starting with low doses, careful monitoring, this drug can be used. In case we need to use it, we can get an echo also done before using the drug. So these are just some pics at 12 months interval showing a combination therapy of topical and oral. So, yeah. So in conclusion, as we all know that for hair growth, it is always good to use a combination therapy. This drug compared to a 5-alpha reductase has a better profile because it is not reliant only on the DHT blocking activity. It has a vasodilating effect, so it can be used in all cases, even in males who have scattered alopecia instead of just, the crown area or frontal blondness. So it can be used in a variety of cases. It has good indications for combination with topical also, and very good alternative to combine with hair growth. Thank you.
Thank you, Iti. Yes, comments, please.
Yes, sorry.
Yes, nice lecture. Just want to comment on minoxidil. Presently sitting here only, I searched on Google whether it can cause hypertrichosis in women. Google says yes. So if any patient who is PCOS or anything, or non-PCOS, and you have given oral minoxidil to females, and if they get hypertrichosis, you need to do free laser hair removal. So,
But one sitting is usually enough because minoxidil allows growth of only miniaturized hair. They are not thick enough.
yes, madam.
I have seen
But
one
for
patient.
medico-legal purposes, it is better to avoid oral minoxidil for female patients.
You have to take informed consent and then start.
So we always counsel the patients
No,
and
you have mentioned in your lecture,
yes.
just to confirm. And the other thing is the main complication of oral minoxidil is postural hypotension. So don't give it in the morning dose as my preference. maybe you may be using, but it can cause postural hypotension. So we advise to keep it bedside. So when you go to bed, then take the tablet. So no chance of falling or postural hypotension. So that is the advice what I give to my patients.
Itisri, there are
Dr. Jain.
here. Two common things which
Mic
is
pass low.
very commonly discussed regarding minoxidil, topical minoxidil. The dryness, the frizzy hair, and the dependency. So, and it is also a valid point. So how do you address that in your patient?
You're talking about topical minoxidil?
Yes, topical.
Right. So the reason why I'm talking about a combination is for that reason, because it is difficult to be more compliant with a topical therapy lifelong. Whenever somebody is started on minoxidil, I always tell them it's a lifelong thing or till you want your hair. So if they want hair, they continue the therapy. This is this is a
dependency,
blanket statement.
right.
This is a blanket statement I always tell them. Now, oral, it is easier to be compliant. You know, it's a sort of a spinal reflex that you will just use it. Topical therapy becomes more difficult because there are functions they have to go to, they have to style their hair, all of those, which is why they end up missing. So when you're using it as a combination, so that gap is bridged. So your topical will be there as and when you can do it, and oral is continued as a blanket. So this is the reason now I have started advising a combination rather than topical alone, because definitely in a lot of patients I've seen that rebound hair fall is there when they've used it for a few months and not been very compliant.
Even oral one also, he has to take for a lifelong.
Everything has to be
Topical
continued
or
till
oral?
they want their hair.
Okay, Dr. Vikram.
Nothing is lifelong in this earth. No one is permanent here. Everything is transient. See, no doubt, Dr. Iti, you have covered very nicely everything. Couple of clarification I'll tell you. Where is Dr. Ashutosh? See, postural hypertension peaks after 10 hours, 10 to 12 hours. So it is recommended to take in the morning rather than in the evening, because early morning we get up for a washroom, and that time most of the people encountered postural hypertension. So as per the cardiologist, oral minoxidil has to be consumed in the morning. Secondly, there are minoxidil resistant patients also because of the congenital absence of sulfonyl transferase in the scalp. So those patients really get benefit by oral minoxidil only. Compliance is definitely a problem for the topical, and you know all what Dr. Jayant was saying, there are a lot of problems. So for them, definitely the oral is superb. And secondly, what ma'am was saying, females do encounter, I'll say, hypertrichosis, but most of the patients, once you discontinue, it goes off. Because as madam, what we are saying, only the villus, they becomes more prominent. Rarely you require LHR. Thank you.
Thank you. Yes.
How the finasteride and the topical minoxidil, is there a synergistic action or?
So finasteride and topical minoxidil, you're saying? So usually, so I avoid finasteride in too many patients, but we even combine oral finasteride with minoxidil at times. So it depends on the patient's indication. Like if we have a crown baldness, we've done a hair transplant for the frontal baldness, then we combine it with finasteride and with PRP GFC treatments. Along with that minoxidil we give to all the patients. Finasteride is a plus minus. So finasteride works as a DHT blocker, dihydrotestosterone blocker. So it is mainly for the male pattern baldness that is there. Minoxidil is having an overall hair growth effect. So as a combination, they have two mechanisms of action. So it is more of a synergistic effect because both the mechanisms work in tandem and increase hair growth, sir.
Thank you, Dee.
Thank you.
The next is Dr. Prajwal Rao. Dr. Prajwal Rao will be presenting laser integration in cosmetic practice for aesthetic outcome.
Dr. Rao is leaving, his flight time is there. When is it? 12:20. His flight time is there.
Good morning, everyone. I am Dr. Prajwal from Mangalore, Karnataka. Today my talk is on something like laser integration in cosmetic practice. I have been trained under Dr. Dinesh Kadam, who is an extraordinarily microvascular surgeon. So laser was a very new thing in my clinical practice. I wanted to share how it helped me in my cosmetic journey because it's very important, because most of our postgraduates will learn more of microvascular. Cosmetic practice is very low in the, especially in non-surgical field. First thing what we want to know is that how laser helps in, does it really matter in our cosmetic surgery practice? Yes, one, because laser offers highly targeted treatment by targeting specific chromophores, that is first thing. Second, it offers non-invasive, minimally invasive techniques or surgical interventions. It reduces the downtime, scarring and patient recurring time, aligning with our present modern patient expectations. And also lasers are also always used as an adjunct to surgery, and it helps in scar modulation and skin tightening, improving final aesthetic results. Patients are increasingly aware of this laser treatment and ask for laser-based treatments by name as well. Some brief history, lasers were started in 1960s. First was a ruby laser, which was used in ophthalmology. Then came in 1980s, which was carbon dioxide laser, which was a ablative laser, which was very aggressive, very high downtime. Then came in 1990s the refinement. We started getting erbium YAG laser because it has a lot of water absorption. The downtime was a little lesser. Then Q-switch lasers, which are used for tattoo and pigment removal. Then IPL, it is not a laser, it is intense pulse light, which was an all-in-one device, which was a little famous. And then hair removal lasers. This is which are like ruby, alexandrite diode lasers. These are very, very common. Coming to early 2000, then we started getting non-ablative lasers, which is affecting the dermis without affecting, which was acting on the dermis but without affecting the epidermis. Then came the fractional thermolysis, which is very good because they were making microthermal damage to the skin. So the healing is faster and recovery is much faster in the fractional thermolysis. In 2010s, then came all the multi-platform came, which has very minimal downtime, like combination of fractional CO2 with erbium YAG laser. There was laser lipolysis, there was vaginal rejuvenation. All this came in the 2010s, where all the multi-platform devices. Present day, I think AI is the future. AI system, AI assisted settings, temperature feedback, skin cooling built-in, picosecond lasers for pigment and tattoo removal, RF microneedling like Morpheus and ultrasound devices, lasers as an adjunct to surgery. These are the common things what we do in the present day. I'll just go very briefly. Classification, we can classify the lasers based on the tissue chromophore what we target. The main three chromophore what we target is melanin, hemoglobin and water. Based on that, we can divide the lasers. The second thing is based on tissue interaction, either with ablative, non-ablative or fractional lasers. We can also, based on the pulse duration, it can be long pulse where we use in hair removal laser. It can be short pulsed or ultra short pulse where we use in tattoo removal, other things. And it can be a continuous wave, which is not really down right now. Continuous wave is not used very commonly nowadays. Based on the wavelength, again, the wavelength, more the wavelength, the more the penetration, but it happens only up to 1064. After 1064, because there's a lot of water in the skin content, so it dissipates. So if imagine that CO2 is 10,600 nanometer, but it doesn't go very deep into the dermis layer. So up to 1064, shorter the wavelength, you have lesser penetration, more the wavelength, greater penetration. But after 1064, it becomes ulta because it goes only into the superficial layer. That is how CO2 lasers are used widely in the skin rejuvenation, vaginal rejuvenation at that part. Coming to the mechanism of action, there are selective photothermolysis. This is, it targets, there is a selective wavelength which is absorbed by the selected chromophore target. And using the pulse duration, you can play around. Like, you can play around whether long pulse or short pulse. The settings actually there is no fixed settings for each laser. Each laser has its own settings, own tuning of the lasers. So it is, if you have seen one laser device, you have one settings there, it will not be common for all the laser machines. And controlling the fluence is very, very important. Fluence is something which is energy delivered per centimeter square. This is the key point in the lasers. Then there is a fractional photothermolysis. As I told, there will be small microthermal injuries done on the skin. So there is a normal skin in between which helps to heal faster and get better recovery and better collagen rejuvenation kind of thing. Coming to thermal effects, there is coagulation, which heats the proteins, and then there will be denaturation and collagen remodeling. There is ablative things where there is vaporization of tissues, especially CO2 laser or erbium YAG laser. There is also stimulation as well. When you put a very low power lasers, you can also stimulate the cells. That is how it helps in the wound healing as well, because it's always confusing to tell lasers can damage the cells, it also can heal the tissues as well. When you put in a low power, it can help in the stimulation as well. Then photomechanical and photoacoustic effects are there in lasers, which is commonly seen in Q-stitched and pico lasers, which is used for tattoo removal, pigment removal, melasma kind of thing. And there's immunomodulation, that is low level laser therapy, where we do for hair growth also, which has a immunomodulation and cellular effects as well. Coming to our cosmetic practice, yes, because this is more done by dermatologists, but I feel this is also has to be done under plastic surgery. Reason is that you get more patients, you get to see more patients, you get to convert more patients, and at the present era, you cannot shoo away the patient telling that this is not my era. So probably, commonly we see skin resurfacing and rejuvenation, commonly wrinkles, textures, pores. So main laser what we use is CO2 laser and erbium YAG lasers. For pigment and vascular lesions, for example, melasma, lentiges, rosacea, all this can be targeted with Q-stitch laser, IPL, and also Nd:YAG lasers. For hair reduction, there is diode, alexandrite, Nd:YAG lasers, which depending on the skin type, we can choose the devices. Coming to next, acne and scars. Active acne, you can use blue light lasers. For acne scars, you can use again fractional CO2 or erbium YAG laser. In body contouring and cellulite, you can use laser lipolysis, non-invasive devices as well. And vaginal rejuvenation, because it is very common nowadays, so we use CO2 laser, erbium YAG laser. Also, we use RF tightening as well. I'll just go through some of the videos. This is how the laser tattoo removal goes. I cannot discuss all the settings there, but this is how it happens when you target the tattoo. So the black pigment is being denatured. So this is the Q-stitch lasers, Q-stitch Nd:YAG laser, which targets the deep pigments. Coming to the laser pigmentation, what we do is that we put a carbon layer over the lips or over the targeted area. Then we do a Q-stitch Nd:YAG laser to remove the pigmentation. It also helps to remove the oils, remove the pores, and also to give the rejuvenation in the skin and required area per se. We also use a fume evacuator, that is very, very important. A laser machine suit should always have a fume evacuator, because otherwise you will be having a trouble, because it's a closed space. You need to have a fume evacuator in the laser device. Coming to the laser hair removal, we can do in two methods. One is stamping method, one is in the in-motion method. Usually when you have a larger areas, like where you have a lot of time, you don't have a lot of time, you need to cover a lot of larger area, you can do in motion. Or if you have very small area where you cannot do in motion, then you can do a stamping method as well. Then we have a CO2 laser where we can use, this is a direct surgical knife, laser surgical knife, where this is just a demonstration how it can cut. This is very precise, very sharp cutting lasers. This is what we tell is a fractional CO2 laser, where we make a multiple channels in that area. So we can see there small channels which has been created, and there will be normal skin intervened as well. That's why the recovery happens much better. But having said, in fractional CO2 laser is not very good in the Indian skin, because type 4 to type 6 usually there's a very high chance of hyperpigmentation. That is how the microneedling RF came into picture, because CO2 laser can be done in the fairer complexion much better. Or if you want to do in a darker complexion, you can do, but at a very low power. Then we have to do multiple sittings to get that results, what we achieve in the CO2. We can also do for the keloids, the CO2 laser can be done for the keloids. We can do for the stretch marks as well with the fractional CO2 lasers. Coming to vaginal rejuvenation, yes, I am more into vaginal aesthetics as well. So we do for stress-free incontinence and also for laser vaginal rejuvenation and tightening as well. So this is how the target happens. So you can see the circumferential laser firing which happens through the CO2 laser. This is a fractional CO2 laser again. Yes, we can do all small processes like laser wart removal, which in the genital region, also in the viral warts, which helps. We remove the outer skin layer and inner skin layer, the epidermis. After we remove the epidermal layer, then we target with this is a diode laser which we are using for the wart removal. My idea is that to show that what lasers can do in your practice, because you can do so many cases because of the laser. We also do a laser liposuction. Yes, I have a laser liposuction, but I do not do very commonly, because reason is that it is very slow. The treatment times takes a lot of time. If you're doing under local anesthesia, probably yes, it would be helpful. If you're doing under general anesthesia, it is a time consuming. Since I have other devices like Vaser and body tet, I would be preferring that only. And we also do a endovenous laser treatment as well for the varicose veins, which is, it's very simple. The surgery what we I am a general surgeon by heart, so I remember varicose veins, it was a dreadful surgery. So when we compare the lasers in endovenous, it is amazingly good. We finish off in half an hour, both legs as well. Then yes, we also do a laser labiaplasty procedure. Laser labiaplasty doesn't have much additional benefit kind of thing, but yes, some people do ask for laser labiaplasty, so that's why we are going with the laser labiaplasty. It's a good marketing tool. RF microneedling, it's not really laser, but it is it's always added into the our laser device. Well, it's common as energy-based devices. So there is a microneedling device. There is also something like Forma, which gives a non-ablative device where you can tighten the skin tight. You get that contour just before the marriage or something. We do this very aggressively. We do this in a combination method. We do this with fillers, with the Forma, or with the Morpheus microneedling. We also can do the microneedling with the body as well. As they told, microneedling in the face, we never go beyond 4 millimeter for the microneedling. The 7 millimeter what we use in the body, because it is never possible in the face because you might hit in the deeper layers. So all face microneedling RF we do only up to 4 millimeter maximum, because patient cannot tolerate so much of pain as well when you go beyond 4 millimeter. But in the body, yes, we go up to 7 millimeter to get that finishing results after the liposuction. Combination therapy, yes, obviously lasers with injectables, lasers with RF microneedling, laser with surgery, sequential treatment planning is much beneficial. Patient selection, as I told, 1 to 3 Fitzpatrick is much better. 4 to 6 is little difficult. Always take a better consent with them that no, you might have post pigmentation. So always use a longer wavelength, so you will have a better results. Contraindication, absolute will be something active skin infections, recent isotretinoin use, photosensitive disorders. Some relative will be pregnancy, lactation, unrealistic expectation, poor compliance. Pre and post is very simple. Pre, we tell to avoid sun exposure, retinoids, antiviral prophylaxis, test spots for darker skin type. Whenever I do laser hammer, I always take a shot on my hand first, and then we go into the patient. Or sometimes we tell you, if there is a facial hair, laser hair removal, we take a shot on the under part of the neck first, so that we give a test shot. Otherwise, you might have a burn here, so that they will not forgive you. So better to do in other areas, which is safer kind of thing. And post-treatment, we give cool compressors, moisturizers, some sunscreens. We tell them to avoid makeup and sun exposure for 2 to 3 days, and topical steroids or antibiotic as and when required, and good hydration and gentle skin care. The workflow is pre-treatment protocols. We take photography, consent, typing, then dedicated laser suit setup. Yeah, laser suit setup is very important. You need to have good ventilation, no reflective surfaces at all. You're not supposed to have one mirror inside the laser device, and you have to have a very good power backup for each machine. Though you have a generator, it is always better to have a small inverter line to each device as much as possible. At least one device for one UPS for 2 devices at least. And train your staff for device operation, pre-post care, because most of the things are done by technicians. We will be training our technicians, and they will be helping so that you can do the OP and surgery, and also you can manage the non-surgical treatments as well. Complications, yes, everyone has a complication like pain, erythema, pH, hyperpigmentation, but all these complications can be treated. It is not like plastic surgery. It's all we can come back. Yes, sometimes non-surgical patients are little irritating sometimes, but yeah, we can manage them. You can just offer them 1 or 2 free sessions, that will be fine then. And realistic expectations, what we tell our patients, you need to have number of sessions. These non-surgical treatments are cheaper, but it comes on like EMI. So ideally, at the end of the day, you are paying more money in non-surgical than you do in surgical, but it comes in a smaller amount, so people do not realize that you are paying a lot of money there. And downtime is involved, and this gradual nature of improvement, we need to take a lot of photographs and show them that, no, this is the result, dekho, ye results hai, because till then they won't realize that they got results. So in non-surgery, that is a problem, that it's very difficult to identify notice the results as well. And there is some temporary side effects which will get resolved on the time. Why integrate lasers into our practice? One was rising patient demand for the non-surgical treatment or low downtime treatments. Laser expands your offering like pigmentation, rejuvenation, scars, hair removal, and positions you as a very tech-forward doctor, comprehensive aesthetic provider, and also it generates repeat visits through multiple session treatment. What happens initially, when they come for multiple sessions of laser, they get converted for surgical also. Somehow they will get converted for some surgery there. So it's always an advantage to have a non-surgical treatment in your armamentarium. If you cannot do, then you hire a dermatologist. That is also okay. And it creates a very cross-reference potential like dermatology, gynecology, and other plastic units as well. Choosing the right lasers, yes, that is what we need. First, you need to buy which laser to buy, because there's so many kind of lasers, so many type of lasers. What we usually tell is that always when you choose, I bought a multi-platform device which is very cheaper with IPL and Q-switch, which is a passive Q-switch. This is how I started there. Once I get a return of investment from that machine, then I move to other machine, then I slowly went. Now we have almost 16 laser devices in my clinic. So, but it became one by one kind of thing. And yes, skin type suitability we need to check, FDA approval we need to check, but yes, it depends on which city you are there. If you're in a tier 3 city, if you're just starting with a laser, that's really a big thing. You needn't go for a FDA approval device because it will be very, very expensive to start with FDA approval devices initially. Return of investment, yes, it is, since it is a multi-session, usually it can be, we get a very good ROI. Usually equipment cost can be recovered within 1 to 2 years if you've done it rightly. And per session margins are really very high when you see non-surgical treatments. Marketing, yes, you need to do a lot of social media reels, some clinic brochures in your clinic, before and after photo books in your clinic as well, offer some demo days or festival laser packages. Run targeted ads, I don't do that, but yes, usually many of my friends do get help because of the targeted ads, so that is also very helpful in the present era market. Take home message is that you need to know when to buy, what to buy lasers, that is one thing. Emphasize safety, results and patient satisfaction. Encourage evidence-based adoption. And lasers not just machines, these are also a practice expansion strategy. When chosen and used wisely, you give a very exponential clinical and financial ROI. This is my team. Actually, I had a dermatologist as well. All these things I learned by my dermatologist actually. He has left, like he had gone abroad for his better. So right now, we both are working hand in hand. So all the vaginal process is done by Dr. Shruti, and I'll be doing more of the other part. So thank you everyone. If any questions,
Very comprehensive lecture. Any questions from the audience?
Thank you for your lucid presentation. Actually, in fact, I got 40 patients having tattoos all over the body.
Okay, sir.
They're all having six packs and very good body.
Okay.
And they are all been preliminarily selected for army.
Okay.
So they wanted the tattoos to be removed immediately and the result to be given in 4 to 5 days.
Okay, sir.
So it was a difficult situation.
Okay,
How to handle such a huge number of persons and to remove the tattoos for the examination so that they get through the practical and being selected for the army.
So unfortunately, tattoo removal is not easy like how we put tattoo, and we have to tell patient that tattoo removal is one procedure where you give much sessions between that, much time of between the two sessions, the results are much better. Like imagine you do a one session today, then if you do within 15 days, you will not get better results. It has to be within 30 to 45 days. Reason is that tattoo has to get disintegrated, it has to come up to that level. So we need to explain the patient that in laser, you cannot do in one session for sure shot. You need at least 3 sessions minimum. And if it is luckily, if it is a smaller area where we can do excision, then I offer them surgical as well. Since I'm a plastic surgeon, I offer them both, sir. Either I'll tell them non-surgical treatment, sir, which goes through this much time.
But only thing, no, they had only one week for going for, that was the
Then
issue.
they should plan it much
And
better
second
before,
is-
sir.
Second is
One
the
surgery cannot help them in
Yeah.
1
Yes,
week.
One
anyway.
is that also not.
1
they have
week
to
is
plan.
too short. Sometimes we can do superficial dermabrasion and skin grafting.
But that
So
also
that is
sometimes.
That
so
also
again
cannot
that 2
possible.
weeks, 2 weeks.
Yeah, that
and
will be possible.
nowadays they come as any military like practice. They are unfit with tattoo.
they
Also
are
many
unfit in the services.
many young generation girls and boys coming with their tattoo of their boyfriend or girlfriend. so before marriage they want to get rid of that tattoo.
True.
So but you need time. You
Yes,
need time.
We need time. sir.
And,
For tattoo removal, we need a lot of time.
yes,
for
yes.
sure.
Which laser will be the ideal one for these patients?
Tattoo removal for Q-switch NDR glazes, sir. This is the one because which goes in a very short span, and also there is it's a baseline Q-switch NDR glazer. There are passive and active Q-switch. Both will work well, but active will give better because we can change the diameter of the lasers there. Like we can change the diameter of that laser. So
Thank you very much.
thank you, sir.
For tattoo removal, you can combine CO2 fractional laser also. You can do CO2 fractional laser first and then do tattoo removal laser. So it will help in 2 ways. The multiple channels made by CO2 fractional will take up the all fumes from the outside, and as well as disintegration of the T2 pigment, but it will come through the epidermis also. So instead of only Q-switch NDR laser, combining it with the CO2 fractional prior or later will be much helpful, and it will help to reduce sitting of 2 or 3 sittings.
There is also another method, sir. It's called as R20 method,
Yes.
where we do a Q6 laser in one session. We wait for 20 minutes and then we do a second session. Actually,
So 2 sessions in one time.
in one time only. That's called as R20 method. But benefit, there is plus and minus there. When you do 2 sessions, sometime you might have a bleb formation there, so which might become like a burn. It might become a burn issue. But plus point of that is because you get better results, faster results, because you are creating a injury, more injury there. So that is also there. You can use that method. Yes, sir.
Thank you, doctor. Thank you
you,
very
sir.
much.
Thank you, sir.
Well done. Now we will have Dr. Astosh Shah, who will be taking 2 lectures together, the consent in aesthetic surgery as well as the GST.
Consent is a very difficult thing. You have to convince the patient, counsel, and if you have taken the consent rightly, even then, very likely you will face a consumer problem if there is any complication or any mishap. So consent is very important to all of us, all the surgeons.
Before that, I would like to announce that those who have registered for today's workshop, kindly leave one by one and just write your names and show your screenshots. Please do it ASAP, okay? So kindly register there. For separately, you write all your names. Just go one by one. Don't leave everyone at a time, okay?
Dr. Shah, please.
Yeah. So I do lots of cosmetic surgeries as well as reconstructive surgeries, but Unmesh has selected me for this practice management and role of consent in medical procedures. So I'll talk you about the consent. So just 4 days before, there was a news that no signed consent and 22 lakhs compensation was awarded to the patient. Now what is consent? It's a process of ensuring that patients are fully informed about their treatment and they can take a knowledgeable and voluntary decision about their treatment. And it's a legal and ethical cornerstone of a medical practice. As well as it protects patients' rights but the practitioner's liability also. And failure to obtain a valid consent can lead you to the legal consequences. Like why consent is necessary? It legally mandates the protection of the right of the patient bodily integrity. Without consent, you can do anything to him or her. So consent is the thing which is required for that. And it also prevents legal complications and accusation on the doctor also. It enhances the doctor-patient trust and communication. While explaining consent, we communicate with the patient better. And type of consent. Implied consent. Implied consent, the patient has come to your clinic or he is rolling up his cuff to measure a BP. It's called implied consent. Then there is express consent. Now, express consent is also a type of implied consent only, but it can be a oral or written. Like if I check a patient of breast implant, I tell them, should I check? So that's the implied consent, oral express consent. Nowadays, before a month only we had a lecture, and in that it's a need of time. One patient complained about malintention of a doctor while examining her, and case of 5 lakhs. If you are examining a child of phimosis, his father can do case. So express consent nowadays is most important if you are male and checking any female patient, or if you are examining a child. Just take a consent that I am allowed to examine. And the best and the gold standard is the informed consent. While you give a proper information to the patient and then it is signed by the patient and relatives. So informed consent is the best consent which is possible. Now this is well explained. If you express consent, then implied. If you are in the boxing ring, means the opposite person is going to hit you. It's an implied consent. And implied by law. So it's in emergency, you need to take this type of consent. Now, essential elements for the informed consent is autonomy. It's patient's own decision making. You cannot force him. Disclosure. Everything should be informed in advance. Comprehension. Patient must understanding what you are telling it. Voluntariness and competence. Patient must be competent enough to sign that consent. So I'll take all this point in detail. So this is what when we explain to patient. For them it is just this type of chart. So who can give consent? Consent, anyone who is above or 18 with sound mind. For minors or incapacitated, their guardians. In emergency, it is presumed that patient has to be managed, but it has to be documented. For medical legal, judiciary permission is required. 12 to 18 years can give consent for examination, but for surgery, you need to have consent of their parents. Under 18 parents and orphan, court-appointed guardians will be required, and they only can sign. Most of the time, in our settings, we see that 17-year-old girl, 14-year-old girl, you are taking consent for fibroadenoma, and patient signs that, not valid. If anything happens, you will be held in court. So parents' signature in below 18. Special consent that I have already done. For sterilization or abortion, you need to have consent of both. The spouse consent is also must. Here I have not mentioned about transgender, but for transgender, if possible, family consent as well as consent of their spouse if they are married. Most of them, they hide the history, but in Ahmedabad there was one case that after changing male to female, his previous wife came to doctor and why you change him. So always try to take this type of consent in transgender surgeries also. So legal, there are so many laws which protects consumers in India. So we are bound by the law also. And landmark judgment in India, Samira Kohli versus Prabha Manchanda in 1995, that patient has severe bleeding and she was taken for laparoscopic examination and she has severe endometriosis. For the betterment of patient, doctor told her mother and did the hysterectomy plus salpingo-oophorectomy. After this, this is decided that consent must be procedure specific. If you have taken consent for laparoscopy, do laparoscopy only. If you are, though it is good for the patient, though it is beneficial for the patient, don't do the surgery which is consent is not taken. These all cases are landmark not for consent, but they save us from the criminal negligence. Now key elements. So what is to be mentioned in informed consent is nature of procedure, purpose of treatment, risk and potential complications, then benefit and expected outcomes, alternative to what you are doing, right to refuse the consent. This is also very much important for us. If you have advised silicone implant rhinoplasty and patient has refused, you need to take a refusal consent that for her case this is the best treatment, but she is not ready for that and I am doing the other surgery. So refusal consent is also must for our protection. Consequences of refusing the treatment and failure to obtain a consent will lead you to the court. So informed consent must be in your room and it is to be, the patient should be allowed to ask questions. It should not be like in the operation theater room. Common mistake what we make in consent taking is blanket or general forms. One form is there, patient will sign and you do any kind of surgery. Not nowadays. Non-understandable language. Patient is Hindi, you are taking consent in English. Not allowed. Taken by unauthorized personnel. Still in India, there is no law that your medical officer or your receptionist or you yourself should take the consent. But ideally, the level of the person taking consent should be that he or she can explain the things better. No mention of risk or alternative in the consent is also not valid, and no re-consent if the plan changes. If you have taken patient for debridement, and if you are doing amputation, or if you are doing the plan of change in any kind of surgery, you need to re-consent. Now the documentation is critical. Consent form are key legal documents, and it has to be saved in your medical records. Documentation is done for court. If you have done and not documented, court will understand that you have not done it. So poor documentation is the major litigation issue nowadays. Written, signed, dated by patient and witness. It includes the procedure details, risk, alternatives, and should be in the language that patient understand. This I will be repeating for so many times that you will take it at home. Not taking consent will lead to the criminal or civil responsibility, medical counsel, or your professional damage. Now points to take note of. Consent is legal, ethical, professional, necessary, must be informed, voluntary, specifically documented, and it protects the patient's rights and doctor's career. And landmark cases also stress that good documentation is required. Now I'll show you some SOPs what we follow in my clinic. Medha Madam, under guidance of Medha Madam, IAAPS is in the process of making informed consent for lot many procedures what we are doing. We are converting it in local languages also, like I have done it for some Gujarati consents. Most of you also will get, and in 1 minute time on the our IAAPS day, Madam will release all the consent in vernacular language. Thank you, Madam. So now consent paperwork SOP in my clinic. It must be different consent for anesthesia and surgery. Patient and relative both has to sign it differently. Anesthetist must also sign, Anesthetist also must sign at this place. And there must be empty space here to write a case specific detail that anesthetist will write as per case description. Now consent must be, it is in Gujarati, so it should be in the vernacular language. And if not, that all informed consent what we are using now is in English. So you need to have a signature of a translator. And consent must include negative consent also. If you are advised something and patient is not doing that, write it. Consent must include 4 things: operation type, operations complication, alternative to the described operation, and 4th, the selected operation and the advantages of the same operation. And it has to mention various diseases in a lifestyle. Here in Gujarat it is written that I have so many diseases and I will maintain. In liposuction what happens? You have done good liposuction, after 6 months he'll come again. So the lifestyle changes are also important, and that must be the patient's own responsibility that you need to maintain. Must have every empty spaces should be filled before this. And empty space should be kept in your consent so that you can write a case specific surgical detail. Patient, relative and treating doctor, most important. As per law, consent is a contract. If you are taking some residence, you will only sign on sale deed and builder will not sign. Is it valid? Not valid. So consent is a contract. Doctor must sign each page with the patient. Then this contract will follow in the court. If you have not signed, patient has signed everywhere, you will not stand in the court of law. All empty spaces should be filled before signing. The ink of pen should be the same for the whole consent. You should not change the ink also. Otherwise, patient lawyer will tell, this is written afterwards. Rewriting must be avoided, and if done, sign it with the date. Doctor and patient must sign on each page, like what we have signed. This is just a simple scar revision, but patient sign, my sign on each page. Date and time of the consent must be filled. See, if you don't write the time also, that is not valid. Consent for the treatment of unwanted complication must be taken, like emergency, tracheostomy or blood product. You need to take it in advance. Patient will not awake from the surgery and then tell. Consent may not include very rare complication like hyperthermia or vision loss. Court doesn't say that you fear the patient. Very rare complication you may not write. It should not give fear to the patient. Concept of real consent. We are in India following informed consent. In US it is real consent. 1% में मर जाने वाला हो तो भी लिख दो. So now in this medical legal era, we need to follow the real consent. We need to inform that 0.005% death can happen. Okay. With the information page, we kept the separate page. Information page we give all of 8-10 pages, but with this we give the separate page. I read it for you. Madam, 1 minute time for that. इस कागज के साथ जुड़ी हुई माहिती हमें, मुझे और मेरे रिलेटिव्स को हमें समझ, अपनी भाषा में समझ आए तब तक समझाया गया है. Till we understand in our language. The other thing is written. इसके बाद हम ये ऑपरेशन करने की मंजूरी देते हैं. इसका जो खर्च है, that is also explained. Expense is also explained to us. And expense is for the operation, not for the result. Result can differ. Then there is written that every complication, everything is explained to us in our own knowledge. This is after operation. We give consent to Dr. Ashutosh and Elegance Clinic team. If about our medical record, we have informed him everything. If anything left, is our responsibility. This is to be written by the patient, but no patient writes this. इसमें ऐसा भी लिखा गया कि there is a, we have given a proper time to question, and we did get the reasonable answer for that. This is written and printed, but with that patient in his or her writing, he will write one sentence that above information is right, explain to me, and I am ready for that. Now the patient is gone. You are winning in the case. So information page, separate page is given. All patient will not write the whole, so printed is given, and here only single sentence is written in his or her writing, and it must be re-signed on the same page also. And last page, always take signature of a witness, 2 witness, one from patient side, and not just sign. Take full name of that patient, take mobile number of the patient, and take the relation. 2 साल बाद याद नहीं रहेगा कि ये साइन किसने किया था, उसका काका था कि चाचा था कि मामा था. So we need to make them relation and full name. If the patient come alone, like in cosmetic surgery, after 18 years, consent is okay. If the patient has come alone, take mobile number of 2 near relatives where you can inform them in emergency or unwanted complication happens. You can do a surgery with 18 years and above alone patient, but you have to take 2 numbers. 1 signature of witness from our staff also. His or her relative may change in the court that this was not done. But our staff, not directly related to operation, like IAAPS or receptionist, you need to take consent of that also. In my clinic, we operate like this. You can see that always countersign each page, make a habit. Always mention for which operation on the first date, consent for scar revision on face. So what operation you are doing, modify and take extra consent if procedure is changed. Always mention date and time here. Mention the consent taken by your staff, mostly doctor assistant. And this is all to be mentioned in your page. Nowadays, video consent is also allowed. The digital consent is also allowed in the court of law. So you just not to tell all patients, I am taking your video consent. In your room, keep a video camera, just put a signal. You are under CCTV surveillance. And you can take a video consent also. And these are the best practices of, I have taken the same repetition, but I'll do it. Use customized in patient's language form. Face-to-face or discussion should be done. Get witnessed and signed. Reconsent if the plan changes. Record understanding. It's not the signature. Use permanent blue or black ink. No overwriting, cutting or whiteout. No ink change within the form. All corrections should be initiated and dated, preferably in patient's native language. Retain a copy in the patient's record and use pre-numbered form to avoid manipulation. Each page you write 1, 2, 3, 4, 5 so that nothing can be changed and you prove that I have no change. This is a consent before operation. And thank you. So consent is not a formality. It's a fundamental respect to person's right to decide. Thank you very much.
Thank you. It is a very elaborate thing. It is open to discussion and
let me set the ball rolling. The consent is often compared to a policy document of an insurance company.
Yes.
Where it's written in small letters and many of the strings are not known to us. And when it comes to the court and all, the counsel for the insurance always defends, saying that it has already been told to them and they have signed. Will that same thing happen here, number one? Number two, do you think all this is practical when you are doing a particular, when you are operating on a particular patient? Filling is all right. Perhaps we all can do that. We can fill those empty spaces, get it signed and all. Is it really practical to explain each and every point that you have mentioned above to the patient? And
so
are they ready to read, even if they can?
So for that, what we do is, cosmetic surgery is mostly planned cases. So when patient comes for consultation and we find that he is ready, we hand over the consent to patient, write the date on which we have given the consent, and after 3 days his operation is there. So we have already written that 3 days were given to patient to read the consent. If he doesn't read, his problem. So it is ideal to give consent prior hand, not on the day of operation. Madam, you were telling something.
Yeah, when you take kin's signature, you should also take that kin's ID.
Means?
Kin's ID, Aadhaar
ID,
card
okay.
or something like that, because there has been a incident in which one patient came alone, she was refused surgery. Then she came after 1 week with someone, and then the doctor operated, went to the room to explain to that relative. The relative had gone and she said I had given him 500 rupees and brought with me. So such thing, there are many things that patients do. So always have ID. Secondly, it is very important, as you said, to keep at the end of the consent, what are the patient expectations, and we write this can be done and this cannot be done. That is extremely important. And for IAAPS consents, what we have done is to avoid too much of clutter. we have made general consents separately for overall complications. For example, in liposuction, there is no need to, in the consent, there is no need to talk about bleeding. But take signature on general consent as well as procedure specific consent. And there has to be separate consent for surgical photography, videography, presence of observers, and use of the photographs in social media, and case presentation, and even your research papers.
Yep.
Because there has been a case in which a patient saw a journal in doctor's clinic. She identified the photograph and the doctor had to withdraw the article.
Sir, I only
have a
asked
doubt,
question.
sir.
Yes, my question is that suppose a patient has come for a cosmetic procedure and he has not brought his family members because he want to hide it. So in that case, what to be done?
If patient is 18 years and above, you can do the surgery, but you need to keep the numbers for emergency. Two relatives, two nearby relatives. You can
No
do
relatives.
the surgery.
Patient not brought any relatives because he want to hide the procedure, cosmetic procedure.
If anything happens wrong, you need to inform someone in emergency. For that, you need two numbers, just that. Otherwise, you can do the surgery on any adult patient with his consent.
His family, his friends also will be okay.
Friends also will be okay.
Yeah, friends are okay instead of parents?
Parents are okay. If the patient is more than 18 years, no one is also okay. But for a witness, you may require a friends.
Sir, regarding time, date and time, you mentioned that thing. And also the change of pen. You start writing consent at so and so time. And for the whole papers, it takes minimum 10 minutes or 5 minutes. And first patient will sign, the attender will sign, then the doctor will sign. I think there is change of time. At least from the starting point, we will write date and time. The consent, it completes by, for suppose, 9 o'clock.
No, that's very much okay. What is, you need to take consent before starting of the operation.
Just before starting of the operation, I am focusing on the consent timings, date and time.
You cannot write the starting time of consent and the end time of
End time
consent.
of consent.
But it should be,
The only thing that you have to be careful about is not to write the consent time after your surgery. You understand?
Yes.
I have been, sir,
We write starting time for surgery also, so it has to be before starting
I
time
have
of the
been
surgery.
caught in a court of law for the timings. Timings of the consent in the court of law. I'm a 10 years back, I'm in government service. At that time, I'm working in civil hospital. Especially not regarding this case, the surgery time, for the time being of bonds patient, where first the policeman came taking the dying declaration. In meanwhile, the judge came. Before starting of the judge, I started the writing the time and date and time of the police persons. And even in the 20 minutes frame, judge came and the policeman got back out. And I started the consent for procedure, the magistrates, date and time I mentioned. After that, policeman came and I consented both. This has been bought in the court of law. Put same time for judge and police, you did the wrong. What is the mistake? What you did any mistake? The judge had asked that. What to do at this type of times? And that thing same applies to the patients of this. Anything can be applied this thing. What will give time and consent, and doctor will send some time, patient will send some time. The times are different. We have to mention the time specifically or not.
No,
and with the same pen you are mentioning. It is possible to sign in the same pen.
You are right for the timing of the confirmation, or we are writing the findings. For consent, it is just needed that you need to have signed before starting of your operation.
There is
Last thing for operating on a single patient, I recently heard this story from a very senior surgeon. Someone did lipoma, plastic surgeon, with a whole towel put on the patient's face. He finished the lipoma surgery, opened the towel, and patient was dead. He had only patient's name. Then on inquiry, he found out that patient is from Bhosri. He had come alone. So he had to put dead body in auto rickshaw and go around in Bhosri asking who this patient is. So it was a very horrible ordeal. It was very long back, luckily. But be very careful, and especially single patients who come from outside, foreign tourism patients.
So you have mentioned the finance part of the consent, okay? So we are working in a private medical college or a corporate hospital. It is not our institution. Are we supposed to do the finance counseling? Because they have a system. There is a department of finance counseling. So why should you utter that words that this must be expenditure?
So this is my clinic SOP. You can change as per your requirement.
Usually in corporate hospital, you are asked to assign a level of the surgery, and then they will talk to you about some additional
in corporates without
items
deposit, you don't take patient for surgery.
No, I am talking about the finance. Why should I counsel the
No,
finance?
it is my clinic and I am responsible for this. So this is my clinic's SOP. You can modify it per your requirement.
Yeah. Would it be okay if it says that the cost has been discussed with us and we are consenting for that, rather than explicitly expressing the amount?
No, amount is not
not
required.
required,
I have just mentioned that explanation of expenses were given.
Madam, I want to just, I joined bit late. Many of our aesthetic patients, they came alone only for the surgeries. Then in that case, how to be sure about everything?
You take all the details, including ID proof of the patient. Then, as Ashutosh said, take numbers of 2 relatives in whom the patient will confide. And now I have also learned from some personal experience that you better call them up and tell that do you know this person? Because patients can even give fake numbers.
Madam, many of the time patient says, I have no one, I am hiding,
Absolutely,
I am
yes.
all alone,
And
I will come all alone, otherwise I will,
Yes.
I will not get operated.
So in such cases, it is our personal call, what gut feeling you develop about the patient. So I have also done many times.
Don't operate
on
actually
single
sometimes.
patient.
Most of the time, if something
you may
looks
not
fishy,
yes.
you not operate.
If
Madam,
there
you are
is
saying the
something
gut-
fishy,
fishy.
yeah.
Thank you, ma'am.
Thank you.
The other topic is GST and impact on plastic surgeons. With your permission.
Yeah, please go ahead.
There.
Most of the doctors are very poor in financial management. And GST has come in a big way.
Slide show
and
karo.
the economic boom is in the country, but it has its own problem. The cost to the patient. So Dr. Shah will highlight about the GST because
It's a big topic. I have given just 15 minutes, so I'll try to do it as simple as for you.
In fact, IAAPS had arranged, when I was there, Patshala with a GST expert. So finally it resulted in a quarrel between the moderator and the GST officer.
Okay. Though anything we try to avoid, if you are in practice, you need to learn and you need to follow. You cannot hide from this. So GST versus income tax. I'll make it easy for you. GST is on turnover. If you are taking 100 rupees for patient, please take 18% extra and pay it to government. You are an agent of a government to collect GST on its behalf, and it's your responsibility to collect and pay to government. If you not done by you, you will be punished. It's not patient's responsibility to give. While income tax is on your income, your profit. So if you are earning 100 rupees from the patient and your expenses are 20 rupees, you need to pay income tax on 80 rupees. So this is the clear bifurcation of GST versus income tax. GST implications, why we need to learn 18% on cosmetic services. If not done, usually the income GST notices will come after 4 to 5 years. So total GST what is to be paid plus 25% interest for 4 years means more 100%, plus 25% penalty of 4 years means more 100%. So if you need to pay 50 lakhs, your GST notice will be 150 lakhs. So 300% of what you pay actually. So ignorance will not save you. I don't know, nahi chalega. They have to pay. If you are in the sea, you need to learn to swim. So making is easy for you. Plastic surgery has two parts, reconstructive and cosmetic. Reconstructive totally exempted, while cosmetic is taxable. Liability of paying GST is always on the doctor, whether received from patient or not. You have to pay. Now, how the healthcare services are under GST? Actually, in 2017, all medical services were exempted from the GST. But hair transplant and cosmetic procedures, hospital premises given on rent, if you have given your hospital on rent, GST to be taken. Other income of doctor like rent, if you have any commercial property given on rent, and if you are only reconstructive surgeon, but the rent amount is coming in your account, you need to take GST and pay it. Sales of medicine, if you are doing pharmacy, GST is must. And sale of food in your hospital, it is also attracting the GST. Other are not. Now last year also, room rent more than 5,000 is collected under GST. So suite room patient, you need to collect GST, though it is a reconstructive patient. Now rules for registration under GST. There are two ways you can take GST number. One is voluntary, other is threshold limit. So what is threshold limit? Threshold limit is when your aggregate turnover turns to 20 lakhs, you need to take a GST number. So aggregate turnover word is most important. It contains all taxable supplies, all exempt, like if you have one entity, Dr. Ashutosh Saab, he is doing pre-flaps also, he is doing cosmetic surgeries also, he is taking rent also in one account. Aggregate, not the cosmetic income. We are in era that cosmetic income तो 2 ही लाख है, तो मेरे को GST नहीं लेना है, भाई तो 40 लाख कमा रहा है. So aggregate turnover. Then you need to take threshold limit GST. For that, we advise make separate company for your cosmetic thing, make separate entity for your reconstructive income and other income also. Like I have Elegance Vidyalay, I do courses for various things, I am under GST. Okay, so my separate company for my Vidyalay thing. So make separate companies to avoid 20 lakhs. So this is one tip. Now this is to understand how we are under GST. Like this Dr. A has 8 lakhs of commercial rental income. Residential rental income is not under GST. Commercial rental income 8 lakhs, reconstructive income of 9 lakhs and cosmetic income is only 6 lakhs and his aggregate is 23. If it is under GST or not? Yes, he is under GST. Dr. B has no commercial income but 8 lakhs residential भाड़ा घर पे भाड़ा आ रहा है. Exempt income of 25 lakhs and his income is 33 lakhs. But no GST required. Both the income sources are exempted for the GST. Dr. C has commercial rental income and total reconstructive surgeries, no cosmetic surgeries. But he has to take GST as he is under one head of GST. and Dr. D is earning only 19 lakhs rupees overall aggregate, though he is getting commercial rental income, but he is not exceeding 20 lakhs. No GST. This is to make easy. Now, there are some advantages to plastic surgeon if we take it voluntarily before starting our clinic for new generation. आपको लगेगा यार पहले दिन से GST 20 lakhs तो कमाने दो. So what is that? Everyone pay GST. If we buy curd or if we buy petrol, we all pay GST. But someone are lucky to get credit of it, and we are under that. It is called input tax credit. What is input tax? It is a tax already paid by a person at the time of purchase or goods in service. Like in our case, we buy Botox from some company and use it for the patient. So government says one person, one patient, only one time tax. So you need to collect, like if you have done 50,000 Botox, collect 9,000 for the patient, from the patient. But while buying Botox, you have already paid 4,000 to the company. So deduct that 4,000 from 9,000 and pay only 5,000 to the government. It is called input tax credit. So means total GST payable by your service, that is in case 9,000, already paid GST for the supply and material, that is 4,000. So you need to pay only 5,000. You can get a credit of 4,000 in your case. Now, why voluntarily? If you are applying a new establishment, new clinic, you will buy so many laser machines. And you have some daily consumable also. How to take GST credit, I'll explain in detail. If you are buying any laser machine, 2-3 laser machine will cost you 40 lakhs. You have GST number or no? That company will take GST from you. So you will pay 47 lakh 20,000 rupees. So 7 lakhs 20,000 you are paying GST while you are starting your clinic and you don't have any GST number. Instead, if you have GST number, mention that GST number in the bill. So that credit of 7 lakh 20,000 will be in your account and you can use that credit for lifetime. So like if you will not, I'll make it simple. As a plastic surgeon, you are opening a clinic. You will not get any credit of GST machines used for exempted service where reconstructive things are done, like diabetic foot machine, wound healing laser, or laser for hair growth. Hair fall is a medical condition. You don't take GST on that. So laser for hair growth is non-GST. You are not taking GST from the patient, so you will not get any input tax credit on this. Though you are paying while buying, but you will not get any credit. You will get 100% of credit of GST, which is used for pure cosmetic. Like hair removal laser, 100% cosmetic thing. Hydra facial, 100% cosmetic thing. You will get 100%. If you have bought a machine of 1 lakh and you have paid 1 lakh 12,000 or 1 lakh 18,000 depending on the machine, you will get the full credit of that. And sometimes it's a mixed supply, like CO2 fractional machine. You will use it for resurfacing, there it is GST applied. If you are removing wart, no GST for CO2 fractional. Q-switch NDAG machine, you are treating melasma, it's a disease, no GST. But if you are doing laser toning with Q-switch, GST will apply. So it's the mixed supply. There you will get a proportionate GST credit. So how to claim input tax credit on capital goods like machinery? So ideal, what government says is 5 years is the time when you use this your. So to earn 20 lakhs for any cosmetic surgeon or a doctor who is plastic surgeon is very easy. So from day one, if you have taken voluntarily GST number, you will use this 7, 8, whatever lakhs you have paid to company as your GST credit. So it is an advantage to you. So useful life of this machine is 5 years. So input tax credit per month is total credit divided by 60, means 5 years into 12 months. So every month you can take this GST credit till you empty it. So for those who are doing initial clinics, investment, so much investment, there you need to take voluntary GST. How to claim GST credit? Plastic surgery, new establishment, two things. Fixed structure, no GST allowed. But machinery and movable structure, GST is allowed. Means your aquarium, if fixed in wall, no GST. But if it is free, mobile, GST is allowed. Plastic surgery daily consumables, used for only cosmetic purpose, like Botox, you can take 100% of credit. If it is used for both, like chemical peel, if you are using for melasma, no GST. If you are using for acne, no GST. But if you are using for pigmentation correction, GST. So there proportionately allowed. And for only clinical use, like you are doing cryotherapy, then no GST will be allowed. GST credit will not be allowed. So for consumable bills, keep 3 files. Calculate GST credit in the way mentioned, like what I mentioned last time. This, mention like this. So always make 3 bills for your clinic. One is pure cosmetic bills like Botox, filler, everything. Then one is mixed supply and one is no GST credit to be taken. 3 bills file for your clinic. Pure cosmetic 100, mixed supply proportionate. What is proportionate? I'll come to that. And pure exempted service, no GST credit should be taken. So calculation of common credit of the mixed supply, proportionate. What is proportionate? Means if you are using your OT material, OT for both things, you are doing breast implant also in the same OT and gynecomastia in the same OT. Gynecomastia is non-GST, breast implant is GST. So the material you are using for OT fumigation, like 1 liter bottle cost you 500. So 500 pe GST, if you are paying, proportionately you need to take. You cannot take whole GST of that mixed supply. So income due to use of your exempt supply divided by the total turnover means if I have a machine or material of 1 lakh rupees, my total turnover is 5 lakhs rupees. And in that 5 lakhs, 50% is cosmetic, 50% is reconstructive. So in that given month, I can take 50% of the credit of the mixed supply. The things which are used for both, you cannot take 100% credit. You can take only proportionate credit. And that proportionate you need to cover every month. So what we do in my clinic, we take whole credit for the all bills and then reverse the mixed supply things. So monthly we do this. So it's a very easy method and you will be saved from GST litigations. Now some tips I will give to you for the GST returns. Like GST returns, monthly or quarterly. Ideally you used to do it monthly. You can do it quarterly, but keeping monthly expenditure, if you are not crossing 20 lakhs, when you are near 20 lakhs, you will know it in advance. Like the financial year starts in April, and in December you find that I am crossing 1950, you need to apply for GST in that 4 months also. So monthly is best, as you can get your idea. Your working type. So many people are in the salary based. They are getting even incentive on their cosmetic surgery, but they are salaried, no GST. Good news, those who are in salary, no GST, even if they are doing cosmetic work. And how to find? Ask your account. Your TDS in 192 means your TDS is cut as 20% or 30% slab. Then you are in the salaried category. If you are professional, your TDS is only 10% cut. So if you are salaried, no worry, do whatever cosmetic surgery you want to do. But if you are freelancer and doing cosmetic surgery in hospital, you are liable to pay GST. How? How to deal with that hospital? GST not applies on reconstructive surgery. You are doing pre-flaps in that corporate hospital, no problem. But if you do any cosmetic surgery, hospital is liable to pay GST on that. Like liposuction you have done for 1 lakh rupees. 18,000 has to be collected by that hospital from the patient and give bill of GST to the patient. But where doctor comes, from that 1 lakh, 50,000 is our surgeon charge. So what? 50,000 plus 9,000. You need to generate bill to that hospital. So hospital will pay you 59,000. Okay. 9,000 is paid for X patient to you. You are paying to the government. Now hospital has collected 18,000. So he will take 9,000 as credit and pay remaining 9,000 to the government. So government get 18,000. You are liable to pay on your professional charge. Hospital is liable pay on the charge what hospital has collected. So when you are freelancer and doing cosmetic surgeries in other hospitals, you need to take this. It's the liability on hospital as well as on you. If you are doing only cosmetic surgery, only reconstructive surgeries in hospitals, take at the financial year end a hospital certificate that no cosmetic surgeries are done and the all income collected from by this doctor in this financial year was reconstructive. Then you will be saved. Now your clinic and your pharmacy, it should be in-house, outsourced or a separate entity. This pharmacy will lead to GST. So always take separate GST registration for pharmacy. Why? GST rate is 1% for traders. Ours is 18%. Separate company, separate PAN card and separate GST registration. Though it can be in-house pharmacy, but make it separate company. Separate PAN card, separate GST number. There is a very good advantage of it. There is a trader's threshold limit is 40 lakhs. Till 40 lakhs turnover, we are 20 lakhs. There is 40 lakhs, no GST number. The main advantage is composition scheme. Traders whose turnover is 1 crore 50 lakhs, they can undergo 1% scheme. No books, nothing. Merits is fewer complication, nothing. No details, no books. Pay 1% on turnover. But they cannot claim the input tax credit. But who will like to take? Only 1%, up to 1 crore 50 lakhs. I am giving an example. Your pharmacy in same GST number of yours will attract 18% GST. So if you are selling a pharmacy price 100 rupees injection and MRP is 400. So MRP is always inclusive of tax. Okay. So if your and your pharmacy GST number is 1, you need to pay 18%. So what happens is 61 rupees will be deducted from your income. So your profit will be 239 rupees. But if you have taken a separate GST number, 100 rupees injection, 400 rupees MRP, your profit is 300 rupees. Okay. So if your GST number up to 40 lakhs, no GST, total 300 your income. If 1%, then 4 rupees GST. So 296 will be your income if you have kept a separate pharmacy GST number. So keep in-house pharmacy, keep it separate. Care while filing the data for GST returns. Now GST portal and income tax portal are connected. So what has some, when you are paying a GST, you need to file in GST your taxable income, your exempt income and their supply which are not under GST. So there is a form. It is not filled by us, it is filled by our CA, but money is ours. If anything happens, check with your CA. In this in this fifth form, exempt, nil or non-GST income. Like I am earning 80 lakhs rupees. My cosmetic income is 20 lakhs rupees. I will mention 20 lakhs rupees here, but remaining 60 lakhs is reconstructive. I have not written it here. Now what portal will do? GST, oh, only on 20 lakhs. His income, oh, 80 lakhs. So doctor, you have not paid GST on 60 lakhs. Notice will come. So if you don't want notice, ask your CA to write 60 lakhs non-GST income. So this is to be care taken by you. As CA, they don't know. We had to know. It's our money. IAAPS has done a lot of work and created worksheet for cosmetic surgery. This surgery under GST, this surgery not under GST. You will get it on the website or you can contact me, I'll forward it to you. Cosmetic procedures, IADVL guidelines for dermatologists. We also do so many non-surgical things. So these are the things. What you write in your data sheet, chemical peel for acne, non-taxable, chemical peel for other taxable. What you write in your data sheet will attract GST. So you need to maintain your data. We have created Google Sheet for that you can take from us. So we are planning a practice management session, lecture series for new generation doctor, which includes GST, taxation, finance and investment, medico-legal implications and policy selection, online, offline marketing, and day-to-day clinic management like team management, SOP and everything. Starting this month end, mostly 5 to 6 lecture series online. I welcome you all. If you are interested in this, we'll add in the groups also. So thank you very much.
Thank you very much.
Dr. Shah, thank you for that important aspect for doctors. Do you advise every plastic surgeon to take a GST number because they will be doing cosmetic procedures every now and then?
Not sir, everyone. I advise two things. All plastic surgeons must have two identity, either your HUF or create LLP or partnership or private limited, then other than yourself. You are on or you are running everything. For government it is 2 PAN card, so it's different. Always make something different for your cosmetic income. So when GST strikes or income tax strikes, only one account will be seized. You will be taking breath for the other account. If you are in one account, everything will be blocked. So always make 2 company. One is proprietor, yourself for reconstructive surgery. Even you are getting rental income in that, you can take GST on that. But the separate company for your cosmetic income. Other thing is, those who are making new clinic and buying so much expensive instruments, why to waste the GST you have paid on that machines? So take voluntarily GST number and take advantage of the GST which you are already paying to the company while buying a machine. If you don't have GST number, the bill will come without GST number and you will not get, you have to pay that 7 lakhs, 8 lakhs, whatever GST, but you will not get credit. But you have in advance GST number, you can take credit of that GST.
I mean, that will work out for the clinics or the hospitals.
Those who
but
are
how about the freelancers? They'll be operating in many clinics, the cosmetic surgeries.
So those I have already mentioned, those who are doing cosmetic surgeries in other clinics, they need to
Have a
take
GST
care
number.
that, yeah, they have to have GST number.
number.
See, sir, 20 lakhs for any plastic surgeon, aggregate if only one company is not difficult. You will cross it anyway. So GST number is must. You can file nil return also.
Yeah.
But you have to have GST number.
So purely cosmetic practice.
कहाँ से?
For a purely cosmetic practice, do you still suggest a separate account? And if you are the sole proprietor, can we still have an LLP?
See, if you are doing pure cosmetic work,
Yeah.
then you can have one income source only. You can keep one company, but I always advise to have two.
No, can we still have two companies?
Yeah,
Because that
you can
makes
have
sense
two
actually.
companies.
Nitishri, there is never a pure cosmetic surgery. Simple acne is exempt. If it is with PCOD,
So, like in
if
my
it is acne, it is cosmetic. So you will understand only when
So,
the patient undergoes
See,
investigation.
under laser hair removal, if you are doing laser hair removal for
PCOS.
congenital patch, not taxable. If you are doing laser hair removal for PCOS, not taxable. If you are doing laser removal for pyloneedle sinus, not taxable. So in your clinic, you will be doing two things. One cosmetic, one exempted. All clinics are doing. But ideally, you should have two companies or three companies if you are doing other work also, like if you are selling medicine, if you are getting rent.
So two more small questions. So the pharmacy that you mentioned, if you have an in-house pharmacy and you're having a separate GST for them, does it need a pharmacist attachment, or it's
That is something other than GST, but yes, you require pharmacist.
then we'll have to do it, because if it's in-house and we are billing it,
In-house pharmacy, if you are separate entity, better to keep pharmacist.
then we'll have to keep a pharmacist, because otherwise we only give drugs that we are. And the third,
Otherwise, you will attract 18% GST. No problem.
Okay, sir. Well, I've heard so much. I'm little orthodox. Madam is there, Mrs. President of APRASO. Have you ever tried to convince the government or the GST or the income tax department
That
to
is a
waive?
long topic and it is spanning. My efforts have been running since the time I was secretary. That time we made the GST guidelines and it was me who contacted IIDVL trustee, secretly gave him the guidelines we had made with reasoning and requested them to make the guidelines. Then recently we also presented to the finance minister, who was very, very aggressive and offensive, but she accepted the IAAPS papers and we are waiting for further contact. Now what is expected, let me tell you clearly now. What they want to know is what is the income bracket of your patients. Now, it is very difficult to collect this data. I have tried collecting data from our members to know how much is the net GST we pay after taking the input credit. But only 21 people filled the form.
So, but
So
the-
average income anyway we never ask. So we are currently at a
But
top
the unfortunate
point.
part is the politicians, advocates, they don't pay. 3 pensions they get, they never pay anything.
So we cannot change
that
the
is
things.
the problem.
We cannot
Yeah.
change the things. We
Right.
have to
Anyway.
be in.
Lastly,
They are fighting
government is
for a years.
government. You know it far better than I know, sir.
That is true, man. But
So
anyway.
as a doctor, we are not paying even 1% of the GST income. But we are soft targets and government knows that this is an easy thing to come. So they will not remove the GST, learn GST, pay GST, try to collect it from the patient. You are just an agent to collect GST and pay to government. Government don't say that you pay it from your income. Make such system that patient will pay GST to you.
It happens here in IMA. We got 68 lakhs as a penalty for GST. But again, the government system where the advocate played a role in such a way, it became completely waived off. So I think there are some doors. I think one should, yeah. Thank you.
one last question that I was asking. So if an external company is paying you the professional fees for the cosmetic surgeries, are they supposed to give you back the GST, because they don't as of now?
You should generate a bill to that company with GST of 18%. And that company can take credit of what it is paid to you. So you are liable for your cosmetic surgery income to the
If
government.
we are liable but we are not getting paid by them, then we have to tell
Then
them to.
also, they pay you or not, you need to pay on your income. If it is proven that you are getting X lakhs from your cosmetic income, it is liable to pay 18%.
But as you said, if it's less than 20 lakhs, it's okay.
Huh.
If it's more than 20 lakhs, it's a problem. And if it's less than 20 lakhs, then we don't need to bother about the GST, then whatever the companies, because the company says they are paying 18% GST. So then they are liable to pay it, we are not, if the income doesn't cross 20 lakhs.
Even though company is in 18%, if your income is more than 20 lakhs and if you are doing any cosmetic surgery, it's your duty to pay 18% GST on your
9% you were saying, na? 9.
No, 18,000. This was an example of 1 lakh bill, so it is to make easy.
No, 9% by the hospital, 9% by us.
No, 9,000. 1 lakh is the bill. So 18,000 was collected and 50% was your income.
Okay,
so
so
you
still
need to pay 18% of your income.
On our income.
So it was to make easy.
Acha. Oh.
Thank you for the elaborate.
I want to add one thing. So these GST people don't understand us. When they come, the same gynecomastia you have to pay because they are totally ignorant. What they see is what your documentation is.
And more importantly, if you don't follow the guidelines set by association, if one person pays for gynecomastia, currently gynecomastia, according to our list, we are not liable to pay whatever because it is in the books, it is a congenital deformity. So if one person pays GST on gynecomastia, they will come after rest of the colleagues who are not paying. So be very careful and stick to the guidelines created by the association so that we can create a united force to put up our points to the government.
So GST officers don't understand medical things. So always follow the IAAPS guidelines and all pay on the same services and all don't pay on the services what are not mentioned.
Yeah. Thank you very much, Dr. Shah. The next presentation is by Dr. Unmesh Kumar Jana on silk protein, role of silk protein in cosmetic surgery.
Thank you, sir. Sir, I would like to announce one small announcement. So, our patient for APRASO thread lift is ready. She is over there. And the thing is, we are having also announcement from APRASO thread lift. So, those candidates who have registered for APRASO thread lift, please come. So, they have announced a price of a 60,800 package, complete pack. They have a price. That will be a lucky draw for all the 29 participants, 30 participants, right? For 30 participants. And we have 5 patients for thread lift now. And congratulations to all our efforts of all our team and to the company as well. So they will be giving this as a giveaway to all the participants who will be putting in the lucky draw. It will be coming in the lucky draw. Lucky draw will be selected by one of our dignitaries. So please, and there will be quiz regarding that APRASO thread lift also for the lasers and also for all the workshop who have attended. Thank you. And we are having also the prize session, quiz session by our Dr. Aparna. Yes, there will be audience question first for the PGs and then for the faculties. Thank you, chairpersons, and all the audience present over here. So, this is again a sponsored Cerigen product, which they have sponsored for us. And thank you, Cerigen company, who have sponsored for us in our conference. So, the basic thing is use of silk protein in wound healing. And after this session, we'll be going straight away to the APRASO thread lift. So, use of silk protein in wound healing. So, they have the excellence in advanced wound care. It is not only used because we thought that it will be used in only diabetic foot or diabetic foot ulcers or the general trauma and all, but nowadays it has found its importance in the cosmetic and aesthetic surgery as well. So the excellence in advanced wound care, the porosity, the MVTR, so all this absorption, it is presented in numbers. Ceriderm is actually characterized by the unique surface morphology of partial or complete non-adherence and the excellent absorption. So it has triple benefit, that is non-adherent, absorbent and faster and efficient wound healing for the mild to moderately exuding wounds. So the schematic of the wound healing, there is a tissue injury. So from 0 to 2 to 5 days, blood clotting, the primary inflammatory cell response and release of inflammatory factors are there. In 2 weeks to 3 weeks, reduced inflammation, fibroblast recruitment, angiogenesis, initiation of collagen synthesis, and deposition and reepitheliation. And 3 weeks to 2, that is the tissue regeneration phase, the scar formation and collagen remodeling and tissue regeneration is there. So Ceridum facilitates this superior healing by modulating these various cellular pathways. How does it happens like a impaired wound healing? In any wound, they will be releasing inflammatory cytokines, and SDF1 and CXCR4 will be released. The fibroblasts, they will be reduced they will be having the impaired function. That is why there will be reduced collagen, deposition, and the angiogenesis. So wound is in chronic inflammatory phase, resulting in delayed wound healing. And how does Ceridum acts? Ceridum facilitates this superior healing by modulating various cellular pathways. So step 1 is, as we know, the phases of wound healing. First is inflammation. So they have given a comparison study between Gelonate, Mepilex, Duoderm, Ceridum. So our product is this one, green color they have pressed. So day 3, day 12, and day 21. So there is a 25% reduction in inflammation as compared to the other products. So there is a ECM deposition as well, extracellular matrix, which is a stage 2. And last stage is blood vessel formation, that is superior angiogenesis in Ceridum as compared to other competitive products. And safety studies, if we talk of, it is non-cytotoxic, non-immunogenic, and non-sensitizing and non-irritant as well. So what are the indications? Any cosmetic surgery procedure dehiscence, they can be used very well in diabetic foot ulcer, in second degree burns, pressure ulcers, wound preparation for the grafting, and surgical trauma wounds and donor sites as well. So what is basically silk protein? It is usually a silk fibrin or silk sericin. So how their name has been derived from that sericin has become a promising biometal in cosmetic and aesthetic wound healing because it is biocompatible, biodegradable, and mechanically strong and bioactive. So role in cosmetic and aesthetic wound healing, post-surgical scar, like management of silk fibrin films as hydrogels and dressings can protect the incision lines after the procedures like blepharoplasty, facelifts, or mole removal. And they keep the wound moist, they reduce the mechanical stress, and promote the smooth and fine line healing. So basically burns and laser resurfacing recovery silk protein dressings, they help in reepitheliation. After when we do the fractional CO2 laser, they help the reepitheliation. Dermabrasion, after the chemical peeling, that reduces the downtime and prevent the pigmentation changes. And skin graft donor sites also in reconstructive surgery and cosmetic cases, they also help as a temporary protective barrier by minimizing the pain and infection. So common cosmetic applications for use in cosmetic silk, healing silk fibrin. That is the films or membrane, they act as a protective barrier for the post-surgical wounds and laser-treated skin. They act as a scaffold for the tissue regeneration, and they are topical anti-aging and post-procedure soothing agents. So the composite silk biomaterials combined with collagen, hyaluronic acid, or chitosan for enhanced healing. So what are the mechanism? They prevent desiccation, accelerates the keratinocyte migration. They have anti-inflammatory properties. They reduce redness, swelling. They promote fibroblast and keratinocyte growth, improving the collagen organization and minimize the hypertrophy scarring. And antimicrobial delivery platform skill can be loaded with antibiotics, growth factors, or herbal actives for targeted release in aesthetic wounds. And there is also UV protection because it has a UV blocking ability. So what are the advantages over traditional dressings? Allows visual monitoring without frequent change in dressing, painless removal, ideal for mobile areas like eyelids or lips, and lower risk of allergic reactions. So future in cosmetic, medicine bioengineered skin substitutes for the scar-free healing. So this was a thigh wound which was silk protein was put in day 1, it is in day 3, and finally in day 9 it has healed with granulation wounds. And it was used in burns, silk dressing in burns, silk dressing applications. So day 8 a post first application, and this is pre-application. Day 12 and day 30, so that is the day 30. So silk protein is biocompatible, versatile product which works wonders in aesthetic as well as general plastic surgery. Thank you.
Thank you, Unmesh. No questions on this. If you have any doubts, you can ask the counter outside. Thank you very much, and let's proceed to the practicals.
So let us move to our thread lift session because the patient and everything is ready over there. Okay, so before sir starts, we'll have a lucky draw. Those who have put your entries in the Nutrova stalls, so we have a lucky draw. We would like to invite Professor Dr. Arun Chaudhary sir to take 3 chits and announce the name.
Sorry. आज एकदम रिलैक्स होके बैठ जाइए. ये फोकस कर दिया. आ रहा है.
Dr. Vishwajit, Bhubaneswari Senior. Dr. Vishwajit Mishra, Senior. Manipal. Dr. Saurabh, Sam Hospital. Dr. Tanmay Mahapatra, Berhampur, MKCG Medical College. Assistant Professor.
हेलो. फोटो तो ले लो. नहीं मैं quickly I am assessing and then you start.
We call our most beloved President of IAAPS, Dr. Medha Bhave. Where is Madam?
मैडम चाय ले रही हैं.
बुला लो. This is a big opportunity.
मैडम आपका नाम, प्राइस.
Huh? Madam is running. She is coming. One more. Yeah. Let her. Madam, you have been so lucky, and we are also lucky with you that you have been one of the luckiest draw coupon in your name. So. Dr. Jiptesh Kumar Behra. Is he here? Yeah. Dr. Jiptesh Behra. He is a post MCH now in SC Medical College, Cuttack. Congratulations to you.
So So basically, before Dr. Bikram Guru goes for the thread lift, I would like to announce and introduce my patient. She is Madhusmita, and she is the CEO of agro-based industries, and she is my friend as well, and she is having the first demo thread lift from APRASO. And Madhusmita, thank you for volunteering, and over to you, Dr. Bikram.
Thank you. So, thank you, Dr. Unmesh, for providing such a nice client who has agreed in camera to get herself the procedure done. So, she has lost around 6 to 7 kgs gradually, and her concern are to have a sharper jawline and a bit sculpted and a slimmer appearance. So, as I was telling, this is a zygomatic arch. So, my entry point will be in front of the hairline, and her concern is this fold and nasolabials, and to take care of the slight jowls which she is having. So my entry will be one entry from here. So what I am going to address, this vector here and one in between. Achha. Is it visible? And one at the jowls. And what I will define her jawline by addressing the jawline from platysmo-auricular fascia, and I will be using the visage excellence, which are 19 centimeter. So similar thing I'll do on the other side, because she is having a bit slimmer face, and I want to maintain her natural appearance. So one vector, second, one at the angle here, and one at the jawline. So here I am using a visage excellence, means 19 centimeter thread, and entry points I am taking only 2. One at the zygomatic arch in front of the hairline, and another one in the jawline to define at the platysmo-auricular fascia. So meanwhile you can continue the next session. So I'll be anesthetizing, giving a local anesthesia. Once the quiz is over, then again I'll come back here. Thank you, Dr. Unmesh. Brief about who is Mani, or should I show the block also? Okay. Give me.
Sir. Sir, you asking?
Yeah. Go.
Actually, I had done before her.
Then give me gloves. Achha. Okay.
So that has added to the
Definition of the jawline, huh? Okay. 6.5 hours. So you all know no-touch technique. Yeah. Please show the, So it's a sterile pack. I'll show. So 19 centimeter threads, 5 each for other side. There is a cannula as well as 18G needle. So let me prep. Can I have betadine? Just lie down. Okay. I'm clean. You can keep your eyes closed. Huh? One more piece I'll be requiring. So maintaining proper antisepsis in asepsis is very essential.
Dr. Vikram, I would like to add one thing.
Yeah, please.
I have mentioned it to you before that this patient I had done HIFU 2 months back, and because of that the jawline is little bit decked up, and she's having still some jaw area like fullness as Dr. Vikram showed. So that will add to her fineness of
Will redefine her jawline further.
Exactly.
More sharper jawline, I'll say.
So that can happen with only thread lift.
Yeah. A bit flat will be better for me. Just see if you can, it will be better. Yeah, that's all. Please focus. Are you comfortable? Now it's okay. It's okay. It's okay. Give me local. So I'm using Xyloc and adrenaline.
Dr. Vikram sir.
Yeah.
Madhusmita is a patient ideal for Botox as well.
Yeah.
Sorry, Dysport, sorry.
It's toxin, you can say.
It is botulinum toxin, yeah. I beg my apologies. Multiple apologies. This was just to comfort the patient, so that she can have a smile.
Yeah, please. So now I am going to anesthetize my entry points. A small prick and the prick
you. I used only 4 cc of local. Now this is the cannula, and I'll infiltrate my tracts. So there is a 18G needle. Just relax. So since a long cannula, you must hold and negotiate into your vector, and very little amount is required. Now I am directing towards my jowl. Give me 18G again. So platysmo auricular fascia is thick. You should make a rent in it, otherwise it will be difficult to negotiate your cannula. Clean it. And the second side, other side. Given already. 18G. Can you turn to other side? Thank you.
So those who have registered for the hands-on workshop of thread lift, kindly note that there will be a WhatsApp group created for thread lift, and there you have a link to register for the thread lift, and then you can get the certificates, proper APRASO certificates, so that you can put it over your new clinic, or if you are planning for a clinic, you can put it over there, and they will be providing you the videos as well to run in your clinic. And they have also a APRASO support website where they'll be giving support for all the videos, and you can see online all the procedures as well. Patient is having little pain, I think.
Can you lift this thing? So once I have infiltrated all my tracts, so here you can have a look. is the 19 centimeter thread. So you go vertically in, and then I will be directing, becoming parallel and addressing the jowls first. Since these are long, I'll make a twist and redirect. Second thread. This I will direct towards the marionette. Be careful about the hairs which are in the vicinity. You can see a part of thread is lying. I will reinsert it later on. This will be towards angle of mouth. Thank you. So you can, the extra part of the thread, there is no need to cut because they have an potential to stimulate collagen and elastin. Just redirect them. Because there's a bit light problem. Give me the other one first. So this will be a shorter length. So maybe thrice I will be negotiating. So we used 5, 4. So one left I will be using for the neck. 18G once again, I'll dial it. 18G. It's almost done. So right side is done. I'll just show you. Saline soap wash. Or just normal gauze will also do. Now give me that cannula, I'll reinsert. Just a minute. Done, only the extra part of thread I have to reinsert. Done this way. Gaya? Not able to see. Yeah. So 5 threads done. Can you sit for a while?
Dr. Vikram, the result is very visible.
Yeah. Just see.
The first instance.
Can-
Only just because
you
of
can
swelling
just-
it.
Yeah, there's a bit of swelling, but you can see right and left, there's an improvement in the nasolabial, marionette, as well as the jawline.
Jaws, yeah.
So same thing I'll repeat on the other side. So if you wish, the next speaker can continue for the anatomy related to the filler or the toxins. I'm quickly finishing up, or otherwise you watch. Give me a betadine soap, gauze. Thank you. Give me 18G. 18G. I'll dilate this one later on. Yeah. So first is toward the jowl. Insert. Next.
Dr. Vikram.
Yeah.
After this, we will give a little bit break to Madhusmita for the disport thing. So in between, we'll be having Dr. Jayant Kumar Das, who will be taking one patient for fillers in the same chamber.
Right. Last one for the space. Give me 18G. Done. So we had the thread for the Smita. Or let me just show. Let me clean. So we are done. Sorry. उसको just
She's the one.
able to see.
She's our I thought a senior faculty speaking.
Someone has to
one OT to another OT.
last one. Able to cannulate, so it should go. Yeah, done. Still left. Right. Clear. Here it is. It is there. The other side show me. This thread is still there. Hold. So we are done with the procedure. Can you sit for a while? I will remove this thing. Just a minute. Let's see any dimpling. So you can appreciate the changes. More defined jawline, nasolabial as well as the marionette has improved. So thank you for this cooperation. We'll apply an ointment and this thing. You have the tape. Just मैं ointment लगा देता हूँ. Just I'm cleaning it. इसको काट देना. अच्छा, यहाँ पे एक थ्रेड निकला हुआ है, we'll cut it. हाँ. Thank you. So thank you. Hello. Yeah, any questions are there, then you're free to ask me. No questions?
Sir, Bikram sir,
Yeah.
I have a question.
Yeah, please. Huh.
So when you introduced the thread first and after it is long, you reintroduced. So it
Yeah.
was above, below or in the same plane or?
Now it is just parallel to the same vector. Because her face is small. Ideally, in her case, a 10 centimeter could have been a better.
Okay.
But since we were having a 19 centimeter, so that's why maybe sometime twice or thrice, as you go upward, the
just judge how much I have to add the lip.
that you have to see how much laxity and one patient is requiring.
And
her requirement was to take care of the marionette, bit of angle and the jowls.
Yes.
This is what her requirement and to sharpen the jawline.
Sir.
So I planned my first vector to take care of the jowl, then upper marionette, angle and the lower nasolabial.
Sir.
So these 4 I inserted here and 1 I inserted to take care of the laxity in the submental area and the submandibular area.
Okay.
So depending upon the patient's requirement, you can always adjust.
And so while putting the thread, sir, I mean to say, while putting the thread, how you adjust the, what exactly the amount you want to lift it?
No. Lift saying or you saying the extent of the thread where you want to
lift.
Lift so you
Automatically
see the
it will
laxity, that you lift accordingly.
Okay.
If there is too much of laxity, obviously you have to do an accentuate the lift.
Sir.
Otherwise the gravity and the depressors are going to pull it down. So you must do an hypercorrection.
Okay, sir.
If provided the patient is willing to.
Sir.
Some patients want only subtle this thing, they don't want any dimpling or a bunching of skin in the preauricular area.
Sir. Thank you, sir.
Sir, may I know the cost of each
Are
thread?
there any complications of this procedure?
Like any complication, infection, hematoma, bruise. And
Let's not discuss the complications now because the patients will be getting, so let's not discuss this.
Yeah.
We can discuss it later at lunch hour.
Right.
Sir, may I know the
Cost to-
cost of each thread? Like,
See, it comes in a box. The MRP, they will be telling you, company people will be telling you. How much? 60,000. It contains 10, one box contains 10 threads. And depending upon the length, The cost varies. The 19, 10 and 8 centimeter.
So we'll thank our patient as well. Please give a big round of applause for the volunteer who volunteered for us. Thank you, Mrs. Madhusmita. It was really nice.
The thread is of white color. Thread is of white color. It comes in HA, PL, CL, that's why it is red. Gents, you can
So,
thread. So we can let them see first this because we will be demonstrating.
Yes.
Then
Seven.
hello, Dr. Vikram. Where is he? I would like to tell you that we can start our thread lift over there. Okay? And Dr. Jain Das will be continuing for the. So Vivek, our workshop coordinator, will coordinate with Dr. Vikram and send the patients. Thread lift. Thread lift. So this session will be taken, this demo session of fillers will be taken by Dr. Jayant Kumar Das, who will be demonstrating few areas where the fillers can bring magic. Over to Dr. Jayant Kumar Das.
Can you lift it up, please? Aditi, can you lift the chair, please? Yes, this one. Little bit down. So, good afternoon everyone. So, we will demonstrate the filler, and you know the filler, it has a rheology behind it, and it has got two roles. One is to fill the volume loss, and another is the lift. So, lift, there is to some extent, if you divide the zone, central zone and the lateral zone, if you are putting filler on the lateral zone, suppose on the zygomatic arch, there will be lift of the this skin, and it will add to some volume also. And if you are putting filler on the central area, so it will add the volume. So you can see she is 46-year-old lady and prominent nasolabial fold, and there is a sagging of the skin here, both the side, and there is a depression underneath the eye, that is teardrop. So my plan is to teach the mid-face field. So what are the things I am going to do? So you learn how to lift this cheek by giving filler on the zygomatic arch, so that the nasolabial fold will get corrected partially. It's not completely, it will get corrected partially. Because to correct the nasolabial fold, you have to give filler on the pyriform fossa as well as subcutaneous medial side of the nasolabial fold. So you should be very careful. If you give filler on the lateral side, the nasolabial fold will be more prominent. So you have to give filler on the medial side of the nasolabial fold. And you have to lift the skin by giving filler on the zygomatic arch as well as the malar eminence. So there will be 4 points, 3 points on the zygomatic arch and 1 point on the malar eminence. 0.1 ml on the zygomatic arch in these 3 points, that is 0.3 ml. 0.2 ml on the malar eminence. So it will lift the cheek like this. But the nasolabial fold will not be corrected completely. To correct it, you have to give the filler on pyriform fossa directly on the bone, so that the nasolabial fold will be corrected. Apart from that, you have to give subcutaneously also. I will demonstrate how to give that injection. And during this correction over the bone, the teardrop part will also be corrected partially, but again you have to give the filler on the inferior orbital rim. So you have to understand the rheology of the product, the filler product you are using, what filler you will give on the bone and what filler you will give subcutaneously, what filler you will give underneath the muscle, what filler you will give above the muscle. So they have a property. So suppose you are giving on the bone, so the G prime should be very high, so that it will lift that, because you are giving directly on the bone, like on the zygomatic arch or on the chin area over the, so that you have a chin augmentation also. And the filler you are giving labral area or the marionette or the jowl area, that is very overactive muscle. So there is a concept of myomodulation of the filler. So basically it will inhibit the actions of the muscle and it will not change because of the over contraction of the muscle. So that filler is different from the filler which you are giving directly over the bone. So you have to understand that. See, now I will mark the area. So you have to hold the zygomatic arch like this. So mark the upper border, then the lower border. This is the zygomatic arch. And the malar eminence or cheek eminence is the transition from the lateral side to medial side. So approximately this is this. So you have 3 points over the zygomatic arch, so that it will be lifted like this. The same thing you have to on the opposite side, the upper border and the lower border and the malar eminence. So 3 points on the zygomatic arch. So there are 4 points on each side, 0.1 ml on the zygomatic arch. So this is equal to 0.3 ml over the zygomatic arch. And on the malar eminence, it is around 0.2 ml. So this is just a guideline, but you can inject as per the patient requirement. And she is 46-year-old. So you cannot lift the face completely with only this filler injection on the zygomatic and malar eminence. Then we'll plan for to correct the nasolabial fold by giving directly over the pyriform fossa.
on the both the side. And also, we'll
Dr. Jain,
correct.
sir, I want to interrupt 1 minute.
Yes.
So we want one more doctor for thread lift because it is started here for the, not demo, like hands-on has started. So already there are 8 doctors over here. One more can join for the first. Okay,
Okay.
see, let her come. Okay, fine. Sir, please continue.
Yes. So the nasolabial fold will be corrected by giving the filler injection directly on the piriform fossa on the both the side. Also by subcutaneous injection of the filler medial to the nasolabial fold. You should be very careful. If you will inject lateral to the nasolabial fold, it will be more prominent. You don't want that. So you have to correct it medial to the nasolabial fold by retrograde technique. And also to correct the some part of the theatre, this area, this is known as theatre, will be corrected by giving filler injection on the inferior orbital rib. And sometimes you have to give filler injection also the soup area. What is that soup area? Can anybody tell me what is soup area? Suborbicularis oculi fat. So mark one point, medial limbus to the extent of the lateral canthus, that is the medial soup area. Then from lateral canthus to the lateral edge of the eyebrow, that is the lateral soup. So you can inject into the soup area, so there will be more volume, or those who have hollowed under eye, you can correct that thing. And same medial limbus to the lateral canthus, then from lateral canthus to the lateral eyebrow, medial soup and the lateral soup. And the DMCF, deep medial cheek fat. So there is a compartment, deep medial cheek fat. So it is here at the triangular area. But it is very prominent in our case. We will not inject deep medial cheek fat injections. We will give only on the theatre. And she has also got prominent marionette line also, but we will not discuss that thing. We will be limited to this mid-face filler only. So before that, let me clean the area with alcohol swab, then I will inject. Any doubt, you can ask me. So this is the alcohol swab. You have to inject on the entire area you have to inject. And before the injection, we had the Prelux cream to anesthetize the skin. So to have a painless experience. Yes. So now I'll start with the filler injection, that is lift with a high G prime. So it will be injected directly onto the bone, that is on the zygomatic arch. And for the, suppose you are correcting the soup component, this is medial soup and the lateral soup, you can go directly from the lateral side to this area, or there is a line from the lateral canthus to the ala. You can go through this point also. So this is 1 ml lift injection. So while injecting, I will retract the skin to just because I want a lifting effect. So I'll start with 1 point directly on the bone, okay? And you should aspirate it, no blood, then inject. Are you all right? Be slow So you have to give 1 unit of this 1 ml, that is 0.1 ml. Okay? Then the next point, the same. And you have to hold like this. Just clean it. So another 0.1. Yes? So you have to look at the syringe. Done. Lateral? Okay. Okay. There will be bleeding because of the prick, don't worry. But you should not inject it into the vessel. So always aspirate. Before injecting, always aspirate. So second point, then the third point. Again on the zygomatic arch. Aspirate, then inject. Just tell me, okay. Done. Oh, so 0.3 ml over. Now I will inject on the malar eminence. So directly on the bone. Right? Again aspirate. Always make it a habit. Don't inject without aspirating. So here 0.2 ml. Right? So I will change the needle now because I have injected at 4 points. So needle is was injected onto the bone. So that's why it will be blunt. So I will change the needle. Now the 4 points on one side is over. The same thing I will repeat on the other side. You can appreciate a little obliteration of this nasolabial fold. Little obliteration. I am not, because she is 46-year-old, a very prominent nasolabial, sorry, I am disclosing your age. So, the nasolabial fold is very prominent. And so there is a little correction of the nasolabial fold. Rest of the correction will be made by subcutaneous. Okay. So you have changed the needle? Okay. Are you comfortable? Okay. Okay. So now, just lift it. Your position should be comfortable while injecting. No, this one. Okay, okay. So your position should be very comfortable. You can come to this side a little bit. This side. Okay. So again the same thing will be repeated on the left side. So you have to lift. You have to lift like this. Okay. With your left hand. Same, the first point, aspirate, don't inject without aspirating, no blood, just tell me Aditya when it is complete. So keep an eye on the syringe, then point 1, then another 0.1 injection on the zygomatic arch. Done? Okay. Just clean it. Always be slow, steady, and hold the zygomatic arch on your, with both the finger on the left hand. Third point, no blood. Done? Done? So 3 points over. So now at the zygomatic eminence. Again aspirate. Slow. It is bit painful because it is touching the periosteum. Okay. So all the 4 points over on both the side. Are you all right? So this is the lift filler, LYFT, lift filler with high G prime, and I have injected on both the side. Then pyriform.
Dr. Jayandas, I'll be interrupting you for 1 minute.
Yes, yes.
We have our laser workshop, it will be going on here. So whatever names we'll be announcing on the first come, first serve basis, please be ready over here, okay? Dr. J. Lakshmi Sushma, she's there. Okay.
And always
Whoever
you
are
try to
willing-
massage it upward so that the lifting action will be more prominent. Okay? You have to massage it upward.
10 people come.
Now her cheekbones look prominent on the face. Then I will correct the nasolabial, that the first point, by injecting the filler directly into the pyriform. This is the dangerous area because the facial artery is passing. So you have to be very careful. You should be on the bone and you should aspirate. Wait for a second, then inject. So you have to palpate it right on the, yes. So aspirate, no blood, then inject. And you should be very slow. And don't move the needle. Once you have engaged the needle, don't move it. Okay. Now you can see how it's quite appreciable. You can see the nasolabial fold, 0.2 ml, 0.2 ml. You can see the nasolabial area. So I will go to the other side. The same thing will be repeated on the other side. So you have to palpate the pyriform fossa area. Right? Aspirate. No blood. Then inject slowly and don't move the needle. Done. So done. So both the area, the upper, the nasolabial fold points corrected. You can appreciate the result. Now it will be more corrected by subcutaneous injection of the filler. So now we'll go for define. So we will correct the nasolabial fold first, then we'll correct the this teatro area with cannula. Comfortable? Since this is highly vascular area, we'll not use needle in this area. We'll use the cannula because it is blunt. It will not rupture any blood vessels. And even if we use cannula, we'll aspirate then inject. The same principle both for needle and cannula. Cannula. No, that's right. So as I have told you, the lift with a high G prime over the bone underneath the muscle. But here we are giving over the muscle. And this is because of the myomodulation. The filler will retain its shape. Even after the aggressive muscle action, the filler will retain its shape because of the OBT technology. They have a technology, NASA and OBT, cross-linking technology. So filler will retain the shape. So before injecting the cannula, giving the filler injection, so you have to mark the site of entry. So this, the site of entry, you have to put a needle here. You can see. Primed. So then you insert the cannula like this and go subcutaneously, right? Up to this point. Gauge, 23 gauge, 23 gauge. So again you have to aspirate. Always aspirate. Because it is highly vascular area, so always aspirate, then inject. How much? So while injecting, I am withdrawing the cannula. So it is retrograde injection. And I am also palpating the cannula. It's subcutaneous plane. So always it's a retrograde injection and medial side of the nasolabial fold, medial to the nasolabial fold. It should not be very deep, it's only subcutaneous. Okay. So again, I am going up, then injecting by withdrawing the needle.
Sir, are you ready? Sir, are you ready?
Sorry, cannula.
So these are all of the scars?
Done? Okay. So one side it's around 0.4 ml on side. Then you massage it slowly.
Whose hand?
Now you can appreciate the nasolabial fold.
Excellent volunteer.
It got corrected.
Which type of healthy volunteers?
It got corrected. You can see on the this. So I will go to the other side. The same principle, asepsis, you have to sterilize the point of entry. You can appreciate this is the nasolabial fold on one side, left side, and the nasolabial fold on the right side. Now it's corrected. You have to pinch the skin like this. Then this is the entry point. Then enter the cannula. So go up to the nasolabial, entire nasolabial area, aspirate. Always aspirate before injecting. Then retrograde. So it's a retrograde injection to gradually I am withdrawing the cannula. Again so I will inject the same amount 0.4. This area.
Dr. Itishri, are you ready for the disport thing?
Done? Done. Yes. Let's see. So just alcohol swab. You can see the nasolabial fold. If required, we can inject 0.1 on each side. But now it has, it will, okay. So you have to mold it like this. It will spread, but it will retain the area where you have injected. Okay. Okay.
Very nice results, Dr. Jain sir.
Thank you, thank you.
So now Dr. Itishri will demonstrate the disport.
That much? That much? Time. Okay, thank you. Thank you, Seema, for volunteering the thing. So we can inject on many sides because of the paucity of the time. You can correct this jowl area also, and also this teardrop area also. But the nasolabial fold, it looks good now. Then after cleaning everything, you have to apply antiseptic like T-Vact or suppressant ointment. Okay? Yes?
And after this fillers, disport injection and thread lifts as well, we can put the collagen peptides as I had discussed yesterday. So over to Dr. Itishri.
So the patient we have done threads in, she has graciously agreed to be our demo patient for the disport. So we all know that the botulinum toxin acts to weaken the muscles, hence reducing the wrinkles. The wrinkles are caused due to repetitive action of the muscles, which causes the wrinkles perpendicular to the direction of action of the muscle. Now it works by blocking the release of acetylcholine at the muscle ending. So a presynaptic action, and that is what causes the effect that is there. So usually the action starts around 3 to 5 days after injection. It can depend on how much they use the muscle immediately after injection. It can also depend on the toxin used. So we know there are various companies that are available, and abobotulinum type A is the most common type of toxin that we use and we inject. Apart from that, the action can last anywhere between 3 to 6 months. So it is also determined by how active the patient is, how good the metabolism is. So if the patient has a very good metabolism or they're very physically active, like a frequent gym goer, maybe their toxin might dissolve in the sense the action might fade away in 3 months itself. So that doesn't mean that you ask them to be less active. It is just that we can inject again, right? And it is not necessary that the entire action will go away. We might need a lesser dose when we do it. So it depends how much of the action they need retaining and how strong the muscle was to start with, right? So this is the basic concept. Now, as with any procedure, we are plastic surgeons, anatomy is the most important, right? The relevant anatomy for this is, so basically there are FDA approved indications for botulinum and there are off-label indications. We inject both. To start with, of course, the FDA approved is what you should start with, and then move on to the more complicated indications that are there. So only upper face is FDA approved or on label for the botulinum toxin. Now, the upper face includes your frontalis, it includes the glabella complex, which is the procerus and the corrugators, and the lateral orbicularis, which forms the crow's feet. So this is the only on-label indications of botulinum toxin. Basically, okay, now about the anatomy, we need to know where the muscle originates from and where it is inserted. So usually when the origin is there, usually it is on the bone. Insertion is usually on the skin, but it depends, it's variable for different muscle. The muscle acts towards the origin. So it will pull towards the origin. So that is how the wrinkles will form, and this is very important to know whenever you are injecting a toxin. Also, as I previously mentioned, the direction of action of the muscle is important. The wrinkles will be formed perpendicular to this direction, right? Again, the depth of injection is related to the depth of the muscle and whether we structure below it, as in a muscle below it or above it, and we have to be very careful that diffusion doesn't occur in the other muscles. So with botulinum, the most serious effect is that another muscle can get affected and it can cause inadvertent relaxation leading to maybe ptosis or alteration of. So we have to be very careful about the depth of needle insertion, the direction where the bevel of the needle is pointing, and exactly in what plane and how many units we are injecting. As in fillers or any injectable, slow injections have to be there. Ergonomics are very important. Make sure that your hand is always supported when you are doing the injection so it doesn't move around. Usually there is no role of aspiration. Some people do aspirate, but again, see, if it goes into a vessel, you are wasting your toxin, but with very little dose, not much effect. So that is the main thing. Now, in botulinum toxin, unlike fillers, you have to assess the patient in a static, that is a resting, and a motion, dynamic phase. Because the wrinkles quite a lot of times, because a lot of patients have started coming in early on, so that wrinkles are prevented and they don't have static wrinkles, but they have more of dynamic lines that are there. So that needs to be assessed. We need to assess how strong a muscle is to assess what is the toxin that will be injected, how much. There is a standard units that for each point we usually inject around 4 units, but again, as you gain experience, you can always decide to reduce the number of units per point, or you can choose more points and then inject over a certain area. To start with, we will go with the basics, what is the standard and safe way of doing the toxin. Later, you can obviously assess the patient on your own and go ahead with that. Now, just a little bit about the dilution of the toxin. So, Dysport has a 300 units, a 300 vial, and usually in 100, in that we diluted with a 3 ml of 0.9% non-preserved saline, which creates the units. So basically Spavard units is what is there for Dysport. So make it equivalent to the units that we know, we dilute it with 3 ml of normal saline. Make sure you always check the diluent is not distilled water, it is saline only, because otherwise the patient will never come back, they'll curse you, it is extremely painful. So always make sure that you dilute it yourself, right? So we'll just assess our patient and, you want to do directly there? Okay. Fine, fine. तो इन्होंने फोकस किया है ना, एक सेकंड कर लेते हैं तो असेस है ना, वाइप कर देते हैं. Can we wipe it? Pallavi, can you just wipe? While we are getting ready, any questions that you have about the botulinum toxin? Okay. How many of you have injected botulinum toxin before? Raise your hands if anyone has injected before. No one? No one has injected botulinum toxin before? Acha. So, हाँ. नहीं, dilution करके दिखा दो. जैसे हम उधर ही करेंगे. I'll just show the assessment right now and then we'll dilute. So I think all of you should incorporate very simple procedure. You should incorporate it into your practices. Even if you're reconstructive surgeons, your patients will, have wrinkles. All of them, obviously. So I know. मैं उनको देख रही हूँ सर. आपको तो आप लोग तो senior. Yeah. Okay. So we can see our patient. Yeah. Right. Yeah. Static lines are not there. So these days we always start. So sir is asking if she's the right patient for this. So basically we always start early. Now it is more of a preventive talks also, so that she doesn't develop dynamic static lines. So basically the dosage is in such a way that we are not freezing the muscle. We are just reducing the activity so that when the activity is reduced, the occurrence of static wrinkles will reduce. So, इसको straight थोड़ा सा, चलो ठीक है, all right. So, okay, one thing is that, as I said in static, as sir mentioned, she doesn't have any lines, very faint lines here, but you can't really see them. Just ask her to raise your So now you can see, yeah. So you have to assess what is the upper border or line of convergence. Just again, raise it again. Okay. So you can see, okay, yeah, raise it again now. So there is a clear line around here where that is the line, that is the topmost wrinkle that is there. So we need to assess that. Also, we need to be safe by having almost 2 finger breadths above the orbital margin, which is the below safe line. So we don't inject any toxin below, otherwise it will diffuse into the orbicularis oculi. We don't want that. We don't want the ptosis of the eyebrows. So the upper line is marked, the lower line is marked. Apart from that, we'll mark the frown, just essay, yeah. So you can see she has classic, these 11s that is there, they will develop. If we don't tox her, eventually she will develop them. She doesn't have a very strong, so we have a body of the corrugators and we have a tail. So this body is the muscle bulk. The corrugators insert superficially into the dermis of the medial brow. So this is where the muscle is superficial. This is the belly, the main belly of the muscle. And this is where your procerus is. Okay. She doesn't have a very active procerus. She doesn't have a wrinkle in the middle. But yes, okay. Now just close your eyes tightly. So there are 2 ways of assessing feet. Either you can ask her to close the eyes tightly. You can see very minor diffuse crow's feet are there. Or you can ask her to smile. She's finding it a little difficult to smile right now after the threads that have been just put. So you can do this. So this is the main assessment. We'll just start off now. आप आ जाइए. Here, back down. Please have.
Itishri,
Is it okay
anything
for
you want?
Huh?
Anything you want?
No, it's okay. It's all good. Yeah, you're comfortable? Okay. So we want the patient sitting up, not lying down. Huh. Okay. We have the camera here, done? Huh. So as I said, dikh raha hai? Can we see it on the camera? No. Now? Okay. So this is the normal saline. Always make sure that you check it. We have to inject 3 ml. You can put a little more so that that wastage that is there, that is avoided. Glove size 6.5. 6.5 anything will do. I want sterilium. हाँ नहीं, I want sterilium. Not there, spirit. नहीं है. I usually put spirit before. So, as with any procedure, asepsis is very, very important. Ideally, clean your hands with spirit before wearing the gloves also. वो कहाँ है? आपका डिस्पोर्ट? हाँ? सीधा मतलब लेटाना है? सीधा? अच्छा. नहीं, this much is fine. Little bit reclining. This is okay. This is enough. You want to? हाँ नहीं. You can just relax. आराम से. Just relax. Yeah? Just relax. Put your head. Okay. Perfect. Perfect. Give me. Turn up. Right? Can we the table down? Mish, have the table down a little bit. नीचे. अच्छा. एक बार नीचे दबाओ. नहीं. This up. Height नीचे होता है. Spirit swap देना. Spirit swap हाँ. ये ले लीजिए किनारे इसमें तो हो जाएगा. ठीक है. अरे I wanted this. This has to be. Your disport has not been taken. Take out the vial. Where is the? Okay, so while the disport vial is out, always keep it in an ice pack. Do not ever leave it on the table and let it warm. How much of it can we see on the camera? This part is seen? Not visible? Okay. Ice pack? Ice pack is there. So just put it, place it. Can we have a flat ice pack? Flat नहीं है? Okay. पीछे करो आप इसको पीछे करो. नहीं, just move this. नहीं, so we always put it. Okay, so one trick is over. You can just put the glove cover so that it's sterile, right? Now the vial. No. Open it. This is sterile. You can't place a packet here. So be very sure and make sure your assistant also knows what you are doing and they're in line so that this doesn't happen. Right. Okay. So this is the vial, right? Yeah. Can I have the... कितने ml का syringe है ये? दिखाओ. नहीं आप मत छो. I'll touch it. Just open it. Yeah, thank you. Perfect. Okay, I want this line now. Just hold it for me. Yeah. I need a spirit swab first if I'm gonna. वो clean है? Opened है वो? Is it cut? ठीक है. आप इधर ले आओ थोड़ा सा so I can be seen. मुश्किल है थोड़ा सा. नहीं इससे नहीं होएगा. I'll have to do it from that only. काटना पड़ेगा इसको ना actually. You don't have scissors. दीजिए ना side से. Unsterile हो जाएगा. ठीक है. No, I need it cut. You have a blade or something. Give me another syringe. So ideally it should be cut, the cap should be cut and then we take it out. Unfortunately we don't have a blade. That's what I'm doing. Getting another one. No, it's better if it's cut, otherwise it's a struggle putting it in. Just turn it. So I'm keeping it just a little more than 3 so that that wastage in the hub that is there can be compensated off and my units don't get, yeah. Now we'll just open this. So if you're reusing it, then you need to clean it with a spirit, otherwise we'll just open it up. So by vacuum, you should make sure that it goes in on its own. You shouldn't have to push it in. ये क्या हो रहा है? नहीं, we don't push it. Give me the insulin walas. So you can just twist this needle up and down so that your insulin syringe doesn't become blunt. Creates a little bit of an opening.
Dr. Tishi,
Yeah.
1 minute. So we'll have the lunch session post this Dr. Itrishi's presentation of demo. After that, we'll be having lunch after 15-20 minutes. So please bear with that.
आप लोड कर करके डालते रहो. हाँ? So around 8 units आप कर लो. हाँ. 8 units या 12 units कर लो. ठीक है. तो आप कितने syringes हैं हमारे पास? 4 syringes हैं. तो accordingly you load 12 units कर लो. ठीक है. आप लोड कर करके देते रहो मुझे. I'll prep her. ठीक है. You just load and give. Yeah. Give me the marking pen till then. कहाँ पे? Yeah. Okay. So we'll just discuss the marking meanwhile she's injections, right? So again, this is a safety line. आप एक बार रिंग करो. हाँ, ठीक है. ठीक है. Normal. ऊपर करो आप एक बार. Okay. Right. So we assess the, we mark the ridge that is there also. ठीक हो? All good. The supratemporal. Okay. Just look towards me. Outline. Okay. So usually we use a 5 points pattern, but you can customize it depending on the bulk of the muscle in individual patients. You don't have to always follow it. It's just simpler. So what we do is usually 1 point we keep just medial to the maximum elevation of the eyebrow. एक बार raise करो. Yeah. So she doesn't have any wrinkles extending beyond this point. So I will just mark my first point here. The second point will be matching this point on the other side here. The third point will be in the midline between these 2 points. And there will be 1 point here just below the superior most wrinkle, because almost 1 centimeter diffusion radius is there for the toxin. And the next point is between these 2, which is here. Right? So these are our points of injection, 4 units each or even 3 units each, but we'll do 4. right? Now just frown for me. ऐसे करो, हाँ, okay. So this is where you can see the bulk. We inject one. This point is vertically down into the bulk of the muscle. फिर से करो एक बार, okay. So as you can see, hers is a little bit more of a vertical muscle rather than extending here. So फिर से. So inject accordingly. There's a little bit of insertion here. This is the dermal insertion. So we'll inject 1 point here into the bulk, 1 point here into this bulk, and a superficial point into the tail. Yeah, that's it. Okay. Tightly close या smile जैसे भी आपको comfortable हो. आँख tightly close कर लो आप. नहीं हो रहा? Okay, then just 1 second. So you have to make sure you're around 1.5 to 2 centimeters lateral to the lateral canthus and just a little temporal or lateral to the lateral orbital ridge. So this is very important. So this is a ridge that I have felt. Just make sure you're a little lateral to this, right? So around here. Okay. Now आँख बंद करो एक बार. Ask her to close the eyes. Tightly करो थोड़ा सा. Okay. So first point would be marked here. The second is 30-degree angle to this. 1 point here and 1 point below that. Try to be very cautious. Even if the patient has a wrinkle extending here, try to avoid that point because you can inadvertently go into the zygomaticus, which can affect the smile. Also, make sure your bevel is always pointed or the needle is pointed outwards, not inwards, because you don't want to go into any other muscle and very superficially you have to point out. Okay. We can stop that abhi, hai na? लोडेड आपका आपने हाँ आ नहीं रहा आप नहीं रहा व्हाट्स द इशू आपने एक लोड किया ओके दो लोड किया नहीं हमेशा ओके सो ऑलवेज योर लोडेड syringes also should be on an ice pack while injecting हाँ ठीक है this is how many units okay this is 12 units right spiritual. So always try to load it in the way you are planning your injections. So if you're planning 4 units, maybe you can load around 12 units in one syringe so that your needle doesn't become blunt. So if you do too many injections, you load too much, your needle will become blunt and it will be painful to the patient. So change your syringes more. Right now we have fewer syringes, otherwise I would have probably loaded only 8. Clean it with a spirit always. Make sure that wherever you're injecting, try not to go through the marked points, otherwise there can be tattooing. So just cleaning it. आँख बंद करके रखना. Just look here towards me. Gauze sterile packet hold. Always keep a gauze ready in case there is any bleeding so that you can stop it, otherwise the patient will have bruising. Okay. So now, as I said, always support your finger, right, so that your hands don't move. Just ऊपर करो आप. हाँ, ठीक है. Ask her to animate, right? Keep a superficial angle. Just go in and make sure you can see the markings. Raise a little bit of a bleb. Inject 4 units. Sit. Confirm, yes. Raise karo. Okay. Relax. Inject very slowly. ठीक हुआ. And you can even use a little bit of help to re-drape the skin over your needle rather than pushing it through. So this is 3 injection points done, right? Raise your eyebrows. Okay. Okay. Relax. Just again frown. Yeah, perfect. Hold the muscle belly. Go vertically down into the muscle. Sorry, a little painful. And just inject slowly. Okay, you're fine. All right. Okay. Now there's a little bit of oozing. Just hold it very slightly. Now we will be injecting another 4 units into the 2 corrugators, the head, the muscle belly and the tail. So the difference, as I said, this one is a little bit of a deep injection. This is a superficial injection. So this injection always make sure that you block so that LPS, it doesn't diffuse into the levator palpebrae superioris. Right? So this is very, very, very important for hold that pressure that is there for even 4 seconds after your injection. Right? So with Dysport, the action is faster, but there are little more chances of diffusion, so just be very careful. So again, we are going the whole length of the needle into the muscle belly. एक बार फिर से करो आप फ्राउन नहीं ऐसे करो हाँ ओके ठीक है रिलैक्स रिलैक्स okay so I've given 4 units but I'm maintaining that pressure that is there. Always keep the muscle belly between your fingers so that you're injecting right into the muscle belly. Okay okay नीडल बेंड हो रहा है नीडल बेंड हो रहा है थोड़ा केयरफुल हो all okay keep checking that your patient is feeling comfortable. Okay so there is a slight ooze at this point. I'm just going to hold it. So now the superficial point, spirit swab. So I'm just going to clean the point because there can be chances of tattooing otherwise. Right. ठीक है, start. Just फिर से frown करो एक बार. Okay. Yeah. This is superficial. That's it. बताओ. How much? We don't need that many, ना? हो तो गया. Can you hold this? आप इधर आओ. नहीं, go that side. Just hold it slightly. नहीं नहीं इतनी जोर से नहीं आराम से. हाँ ठीक. Okay. Just frown for me again. Perfect. Okay. दर्द हो रहा है इसमें बस बस ओके that's it छोड़ो ऑल ओके ठीक नहीं ओजिंग हो रहा था इसमें हाँ स्पिरिट सो जस्ट लास्ट पॉइंट्स हियर एंड हियर ठीक है डन जस्ट क्लोज योर आइज gauze. Okay. So ideally I should inject this side from here and the other side from here, right? Because I don't want to go like this. I want to point it outside, laterally. Just turn your face towards me. So just smile or close your eyes slightly. Okay, perfect. All right. So we're reconfirming the points. Again, now whenever even if we inject here, there'll be a diffusion radius. So just make sure that you're spacing the points. Here, keep the bevel up. You won't be able to see it, but look at the bevel, keep it up, and then inject. हाँ, मैं बोला तो था, आप लोगों ने किया ही नहीं. कर सकते हो नीचे? करो करो करो. कैमरा रीएडजस्ट हो जाएगा. नहीं आप मत करो रुक जाओ. आप गलत कर रहे हो. You are lowering this. You have to lower this. No. This is हाँ. Subdermal तो फिर. Yeah. Okay. Bevel up again. Make sure you do that. You can see I'm just re-draping the skin over the needle. Painful? Okay, we're done. Okay. So this is it. I'm just going to give this side also. So we are done with the demo for here. It's okay. Just move that side now. आप नीचे देखो एक बार हो जाइए. माइक ले लो मेरा. माइक ले लो. हाँ हो गया ही बंद कर लो. बाकी ये तो हो गया ना, सेम ही करना है. माइक का अगर आप चाहिए तो हाँ बंद कर दो. ठीक है, फर्क नहीं पड़ता. हाँ ये रिक्लाइन नहीं करना है. द पेशेंट ऑलवेज हैज टू. नहीं हो रहा तो नहीं हो रहा. दैट्स ओके. जस्ट लुक टुवर्ड्स मी. या स्माइल अ लिटिल बिट. Okay? In full? I'll wait. Just 2 more points left, we're done. Okay? Dialogues का effect चला गया उनका. Last. ये ज़्यादा ही है. Okay, last point. Smile again. Okay, perfect. So now that I'm still on the mic, make sure that you don't rub the points ever. Always just make sure that you do the cleaning. Very slightly clean with saline. Avoid spirit. Sometimes it can deactivate the toxin. Clean very slowly with saline and put some antibiotic ointment on the entry points. That's about it. The post-op advice to the patient is ask them not to lie down immediately for a few hours. To avoid, very, very, very important, no facial massages inadvertently. They should not rub their eyes or do anything. For at least the first week, they should avoid it. Any facial massages, I ask the patient to avoid for 2 weeks. Usually 1 week is okay, but 2 weeks is preferable. No heat treatments and no other procedures. If they're planning any other procedure, they should check with you and then plan it. So those are the main instructions that are there. And alcohol, if possible, to be avoided for at least 24 hours. Green tea and vitamin E and couple of blood thinners should ideally be avoided pre-procedure and even for a few days after, so that risk of bruising is minimized. Also risk of bruising is minimized when you don't need, मुझे spirit नहीं चाहिए, saline चाहिए, never spirit. So also the risk of bruising is minimized if you immediately just put a point pressure on the point if it is oozing. That's it. हाँ. बस ठीक है, कैमरा बंद कर दो, हो गया. Just going to clean the points, ठीक है? That's it. Instructions मैंने आपको पहले बता दिए थे ना? Any doubts? कोई doubts? हाँ. अभी बस 2-3 दिन के लिए आप avoid करो, है ना? आपका vitamin E जो आप सकते हैं. वर्कआउट अभी नहीं, कोई हैवी वर्कआउट अभी नहीं करना है, क्योंकि क्या होता है ना, जो आपका टॉक्सिन है वो दूसरे मसल में जा सकता है ना.
Dr. Itishri, is it over? Shall we send the second patient for hands-on? Okay. No. Hands-on for disport.
क्या हमारा?
कुछ नहीं होता, जो भी आप बोलोगे हम सुन लेंगे। हैं? नहीं चाहिए? राठौर सर, एक सेकेंड आपको माइक लगा देते हैं। एक्सक्यूज मी, एक्सक्यूज मी, एक्सक्यूज मी, एक्सक्यूज मी।
वहाँ पे स्टेराइल है देख के। Thank you. Yeah. So very nice demonstration of toxins by Iti. Don't go towards the thyroid cartilage. Stay parallel to it. You can always do this thing, na? Parallel. So we are not going to address the thyroid cartilage skin. Na? We are just concerned about the submental area. And submental area starts from, you know, the submental depression, which is just behind the posterior border of mentum. And then it is at the cervicomental angle. So that area is the only target. Go. When you are getting resistance, you withdraw and then go, because the threads are getting engaged. So that is not allowing you to forward movement. I think, yeah, then withdraw. Till there, then take a twist and then re-enter.
Okay.
The way you have entered, it will re-enter in that plane only, na? No. Just chin up, go. Yes. Parallel, and you can go below also. Resistance means withdraw and then go. That's a good way. I think it's done. Withdraw. Complete. So let's do on the other side. First, anesthetize it completely. Give me a local, Vilas.
Please bring the camera here.
I am giving you 3 ml. Do justice. So upper was done. You do middle nasolabial unit. Local. Hold here. You want to see, it's like the base of the ana, middle of the nasolabial, lower. You can take one at angle. Upper marionette, middle marionette, lower marionette, if they are more prominent. Then the jowls, you can come to the anterior border as well as the posterior border.
So we have the who have registered for Disport. If your people are free, you can come over here. It will be taking 10 minutes only. You can after that go for
to
lunch.
the middle.
And those who have finished the thread lift, you can straight away go for lunch and come back immediately for your next session of lasers and
Very
Disport.
little pressure. Come out quickly. Come out quickly. Land up depositing maybe 2 ml.
Come here quickly as well.
Not 2 ml, I'm saying 0.2 to 3 ml. Yeah, it is there.
Nilima.
Have a hang of lower nasolabial.
who are registered for
and the
disport,
angle of
please go
mouth.
there to the first stage where the Dhamma chair is there.
But madam, it's not going to cover the entire area, and I don't want, huh? But still it is not going to do the entire area, infraorbital block. You have to then take a mental block, you have to take a auriculotemporal block, nerve block. Still it is not be going to cover the entire area. This is very easy, na? This helps in making a tract also. You have a feel of it. You've done the marionette? Okay. Do jowls. Yeah, you take an entry here. First, local, preauricular area. Preauricular area is in front of the tragus. Front of the tragus. Where is tragus? Yeah. Not so much. You will be having difficulty. There is a depression there, na? Don't go see deeper. Which artery is there?
We can see a very active attendance in Dr. Rathor's thread lift session.
Achha, arey, I thought ki you are being surrounded there on the screen.
नहीं सर आप ही है.
नहीं. It's your aura. Iti Shri's aura. Yeah.
So those who are standing for disport,
Yeah.
please give your attendance to Dr.
Yeah.
Subra.
Okay.
Volunteer for disport.
Good.
Volunteer for disport. Dr. Unmesh.
Change
कहाँ है?
to cannula. Go. Sir, go vertically. You see the way you entered, same way you can go. Can I have this thing? Vilas, give me sterlium. Sterlium. Thank you. Be careful about your drapes also. Till the anterior border of the jowls and the posterior border of the jowl.
Suppose, see, each insulin series, it is 1 ml. And there is 40.
Are you in sub-Q or you are in buccal? Sure. Yeah. Angulate, then they adjust, na? Yeah, very good. Right. Good. Go ahead. Go to this area. Pinch and go, na? Pinch and go. It's a blunt. Cannula is blunt. Always cannula is blunt. Needles are sharp, cannula are blunt, by definition. Yes. Now? Yeah, jowl. Good. You want to give one more tract? No, here also, posterior jowls you do. Hold, long thing, hold close. You're going towards angle of mandible.
Those who have gone for disport injection, you need not wear the gowns actually, because that is the unsterile area. You could have finished the thread lift first. Okay. Yeah, you go there.
You enter into the neck.
Charla.
Okay, chalo. Let's start. Start with the jowls. Do first posterior border of the inferior jaw. Here. Go beyond, yes. Withdraw. Don't come out completely. Then take a twist. Insert parallel to it. If you are getting resistance, withdraw, then go.
Start with
For,
start with
forward,
how you take the
retrograde,
photographs.
forward, retrograde, forward, retrograde.
What are the areas you will inject botox?
नहीं पहले photographs
हाँ, हो गए, हो गए.
अच्छा हो गया.
What are the areas you will inject?
First point आप करो next.
Yes, withdraw, again go. Stay parallel to it. Yes. Resistance means withdraw. Be careful, you are giving too much of pain by pulling the lobe. This poor chap has not done anything. You are scolding him so tight. Done? No resistance? Remove it. If there is no resistance, complete.
Sir, हर एक
Yeah.
बार reverse करके फिर अंदर जाते time we have to disengage.
Yeah. Do. Yeah. Come next. Be careful. This is trial area, my dear. Yes. No. Complete the jowl, na. She has gone to the posterior border. You go the anterior border of the jowl. More, yeah. It depends length. Then maybe then you measure it because it comes in 19, 10, and 8. 8 are for the eyebrows. 10 in a mid face. It's good. Yeah. You measure. Otherwise, you have a sterile scale, na. Usually we have. Good. You have gone. Yes. Wonderful. That. Now you come. Just before reaching here, then you can disengage the, engage the cogs, the barbs. Yeah. Then do. Yeah. See, the second or third, when you are inserting, there will be no resistance. That means the entire thread, you have done 2 or 3 layers of it. Getting resistance, isn't it?
Is anyone left for the laser workshop?
Reach.
Anyone left for laser hands-on? Please do that and immediately go because they are packing up.
Done.
हो गया?
Yeah, reach. Reach.
From the
Again,
disport
just
side,
give a
anyone
try.
having
Give
pending laser workshop?
One more and see.
Okay.
One person is there, she's just coming in.
Please have it in 2 minutes and then go.
She's coming, she's on the
No
way.
resistance. Remove. See, everything is gone. Good. So come. So 10th person. 9th I'll say. One was demonstration. Okay. Go ahead. So 2 jowls we have addressed from the preauricular. Now we have a on the zygomatic arch. So you address the marionette, then angle of mouth. Can we have a second box, Vilas? Okay, welcome. It's a sterile area, my dear. All subcutaneous. Huh? Any done? One. This is second pass. Second. Yeah, good. Resistance you are getting. Withdraw. Go. Two flow. You go. It will be very easy. Right.
Two, but that one.
Only 10 threads more. So we are doing more on him. Na? Done? Withdraw. Then again. Good. Withdraw. I must say this patient is very tolerant. Wonderful. So next. Yeah, welcome. So he has done the lower nasolabial. You do the middle nasolabial, then other one will do at the upper nasolabial. Good. That is just to hold the thread near the eye when it is being packed. Otherwise, now with gravity, if you shake, it may come out completely. Yeah. Withdraw. Withdraw. Take a twist. Yeah. Resistance to two fro. Good. So you can see he is transgressing into the upper part. Withdraw. Again go.
No, I burnt my iPhone already with that putting like this. The screen is gone. I bought a new one.
See, you are going near the lid cheek junction.
One iPhone is already gone.
Already that area is having decreased lymphatic. So you are further destroying, he will be developing a malar edema. So stay away from the nasolabial fold, lid cheek junction. Still there, still inferior to it. Withdraw. Did you feel it is there? I don't think so, it should be there. 3 times, no? Yeah. Yes, doc. Who is going to come? Come, wear gloves then. Go that side. from that side. Huh. Do neck. There is a one more is left. Mid face. हाँ नहीं नहीं अभी नेक में डालेंगे नेक में कम से कम 3 डाल सकते हो 3 both sides हाँ yeah start
not working.
this you direct huh? In between this part where there is a this mole na direct at that हाँ
Oh, अच्छा 80 80%
yes pinch go very nice wonderful doctor yes very good very good bit more yes now withdraw just stop here withdraw withdraw keep feel here come then disengage no
Excuse me. Those who are having Dysport injection, kindly give, kindly tell your names.
Twist and then go.
The one who is taking the attendance, okay?
Stay parallel.
Serially tell your names.
Good. Yes. Withdraw.
And those who have gone for Dysport, if you are not done with lunch, you can come for thread lift because 2-3 people we are wanting here.
Again.
For the hands-on. If you are done with Dysport, you can come.
So you are getting resistance, so forward, backward, forward, backward. Yeah. Withdraw. You still feel something is there, then again make a pass. Complete. Now bit is there, again reinsert, maybe bit parallel and down. Because as we go upper, the distance get decreased. So maybe 4 times 19 centimeter you have to insert. Yeah. Withdraw, you have reached. Not so fine. It has to be subcutaneous only. Subcu. He is already a thinny person. Withdraw it. See, I think there should not be any thread. Complete. See, very nice. Yeah, you just repose it. Take a gauze piece or with the hand. We can see very nicely. It is built up. See, clear. So now we will be doing his neck, madam. Already one thread was given, so you can use, already madam it is anesthetized. We are not going in that part of the neck, we will be taking only the submental laxity we are taking. So cervicomental angle is at this level and we always remain at least a centimeter below it in order to preserve the injury or prevent the injury to the marginal mandibular. So you can take, and platysma auricular fascia is this one. So this straight, so it is behind it. So from here we will be taking one like a V. 3, 4, you can, he is having bit less requirement. Already one given, we are giving one more. 2 on both sides, at least.
Thank you, sir.
Okay, welcome, yeah, ma'am, it's going very smoothly. If you are in subcutaneous, it will go smoothly. Go till midline, then withdraw. Yeah, go ma'am. yeah, midline, yeah, you have reached. Withdraw, then don't come out completely, take a twist so that there is a V is there at the entry point, and then bit of anterior, bit of posterior, means forward, retrograde, forward and backward. Neck infiltration is not done. You will. नहीं ये कैनुला है नहीं एक इसका कैनुला ऑल साइज आर सेम फॉर इन्फिल्ट्रेशन कैनुला दैट इज एन इन्फिल्ट्रेशन कैनुला Done, madam? Wow, wonderful, ma'am. You can see, yes, you put it inside. Insert. Push any direction so that you should not poke. Still it is there, ma'am. Very nice. Done. So you want to insert one more or you want to insert that side? So you can insert here, no problem. Yeah. Or otherwise, other side you can do. Yeah. So come this side, sir.
So after the
Local
disport
first,
and
local
laser,
action given.
you can directly move for lunch and come back in half an hour immediately.
Take 18G. Can anyone help? Vilas. थोड़ा सा लोकल चाहिए होगा ले रहा हूँ at this level, already local was given here, so you just check. Change to cannula. Hmm. 18G. Hold. Go vertical or that way only. Whichever way you feel like you should go. And remember the entry. Hold close. बहुत कम देना होता है. In one tract hardly you require 3 to 4 ml. Sorry, 0.3 to 4 ml. 0.3 ml usually. Start. You are very close to the mandible border, huh? Good. Go up to midline. Very good. Please withdraw.
So after this lunch, we'll be having a session, panel discussion as well. And there will be a lucky draw also from APRASO. So let's see who wins today and who takes away the box along with him or her. So the one who will not be in the auditorium will obviously not be rewarded. So they have to be present over here to collect the prize. The one who is not present, mark my words, those who are not present, they will not be given the prize. हेलो पलि आस तौक जो आमर ये ऑडियंस ये बस जल्दी आस हाँ ऑडियंस ये बस जाओ भिड़ ना तो आस हाँ ग्रुप फोटो पूरा हाँ कर लास्ट लास्ट को जी पिला अच्छे कर sign will be mine. हाँ वो हाँ परेश को पूछेंगे देखिए कौन नाड़ा Good afternoon everyone. So the final session of our Raabta 2025 is a panel discussion. So those candidates who are looking at the thread lift can listen here as well. So you have 2 years hopefully. So panel discussion regarding the medical legal issues in the aesthetic surgery. So I would request Dr. Medha Bhabe ma'am, Dr. Sunil Raut sir, Dr. Biswajit sir, Dr. P.V. Sudhakar sir to grace the dais. नहीं नहीं प्रिया बंसल की बात ये नाम है हाँ सुना अरे चैट I would like to request Dr. Ashutosh Saha sir also for his expert insight. एपटे दीटा चेयर पकड़ दे अरे एट दिरे से चेयर नहीं आस रे बाबा एट दिरे चेयर पकड़ दे Good afternoon everyone. Good afternoon to those who are doing your thread lift also. Yeah, hi. So this is the last session of this evening and we'll be bidding farewell to all our dearest delegates. So this is all about the legal responsibilities and legal issues in the aesthetic surgery, right? So consent and documentation was very nicely presented by Dr. Ashutosh Saha sir and we had very nice insight about that, so I won't be going to that consent part. and documentation part. Next, we'll move to ethical boundaries. So, I'd request to Ashutosh sir, what is the surgeon's responsibility when a patient has unrealistic expectations, especially in rhinoplasty or in liposuction? Sir, you can explain.
See, if you feel that patient has unrealistic expectation, you may try, you show the results, you show the documentation, and try to convince him if he is coming to realistic expectation. If you continues after your effort, if he or she is still unrealistic, we should avoid that patient.
Fine. Anyone else like to add?
That's what basically about it, but you know what? When he's talking about making him realistic, is if somebody comes with a photograph and asks you to be shown exactly the same result, you say that it is not possible, it is not realistic. If he understands, fine. Our aim is only to improve, not to make someone like the other one, because each individual is different in this world. That's how we basically try to convince. If he's not convinced, better to say goodbye to him.
Yeah. I would make
Nowadays, ChatGPT is helping patient a lot. Yes. They will put their own photograph, make my bridge small, make my LR reduction, and they'll get their own photograph, not others' photograph. They get that we also can use. We can crop the Aishwarya Rai's nose and put on her face, and we can even show that this will not look good. But you try only once or twice. If she is not coming under realistic expectation, leave that patient.
Yeah, and there are many apps also like Arbria app which we are using, but they are also downloading some apps in Play, Google Store and all, and they are comparing it with them and then showing that this should be pre-op, this should be post-op.
Also, you can emphasize on the possible complications if they want to pursue the unexpected, unrealistic expectations. That also you can add.
And next question to Madam.
Actually, apps, I had a very bad experience, especially with rhinoplasty. I started spending almost 1.5 to 2 hours creating different combinations, and finally myself and patient both forgot what exactly patient wanted. So I just gave up the subscription.
Again, Madam ma'am, question to you. What steps should be taken if a patient develops a complication despite your proper care?
Can you repeat, please?
Madam, what steps should a doctor should take or a plastic surgeon should take if a patient develops a complication despite proper care?
Yeah. So on this, I have a chapter written in a dermatoplastic textbook called Breaking Bad News in Plastic Surgery. And in ASearch 26, we are planning a role play with a very famous psychiatrist, Dr. Harish Shetty, and our students will actually play patient and relatives. So basically, what I do in my practice is I insist that sensitive patients like rhinoplasty, breast augmentation, they are accompanied by one and the same relative at the time of counseling and at the time of post-operative period also. If I realize that complication is occurring during the operation, then also I inform the relative immediately. That is very important, and what steps we are taking, of course we reassure them. And then even before taking the patient up, I tell them that if you trust me so much that if there is a complication, I will do my best to get you out of it, then only get operated with me. And then don't leave any stone unturned, like because the package is small, I will not admit. Let the money doesn't matter, but no aesthetic surgery patient should be compromised in any way. Keep the patient for 1 or 2 days extra.
That is the main thing, madam, what you told, that about like if something is in Aishman package or if something is in like small money package, we cannot do injustice to the patient. That is a very good point, valid point, madam.
It is very important because if you are earning from 300 cases, that one case which is going to ruin your reputation, you must spend your money to save yourself.
So hand holding is must. You need to be honest to accept that there is a complication, and you need to tell it to the patient in a nice way that he'll not fear. You need to show the capacity to patient that I can bring you out from this complication. If needed, you can take help of any good doctor in your fraternity or other fraternity also. Also, if you tell that patient, doctor that I am in soup, he will also help you out. And no charges, at least surgical charges, for any upcoming operation of that patient. You may explain patient that some dressing charges or hospital charges, we cannot help it out. But your charges, you should leave. Then patient will also understand and you can help him out.
So one small incident, okay.
There is a little bit of glitch there because when you give away your remuneration or pay the patient even for taking the patient to other hospital by ambulance, that can be taken as admission of crime by in the court of law. So in such patients, it is better to consult your lawyer and do the needful.
So most of the patient you know by their words in your OPD after you explain the whether this patient is going to do you harm or not. So if you find that patient is good, trusting you till now, then you can leave the charges. It's not committing that I have done mistakes, so I am paying. Madam is very right. If you do that, patient may understand that doctor ka bhul tha, isliye usne paise. So don't give money, don't give remuneration. That is not to be done. If you do the remuneration, you should have the help of your medical legal expert and then do it. So no remuneration, but don't take charges for what you are operating. For like if you have nipple necrosis and if you are doing debridement. So do it for your charges, you can leave it. But hospital charge, dressing charge, minimal charges should be taken. Yeah. And the other thing is keep the documentation ready before patient goes to court. So your paper must be ready that this is going to be litigation. So keep your papers ready. Though you are helping out the patient, keep your papers ready.
I want to add one thing. Preoperative counseling regarding the complication. Your question was on complication. If you have previously preoperatively counseled about the expected complications, then also patient will understand. In one of my case, fortunately, I had a case of abdominoplasty with skin necrosis because huge divergation of recti as well as huge mesh put. There was necrosis of the flap, but putting again back, again skin grafting, I came out. But that patient searched so many plastic surgeons and queried, and he came to know that what I have counseled preoperatively, exactly all other plastic surgeons are saying same thing. Regarding complication, preoperative counseling is very important.
Sir, even though we explain the patients about the related complications, but there are many instances when unrelated complications will happen. I would like to add one anecdote, not anecdote exactly, it happened with me incident. I had planned for a varicose vein surgery for a patient. Usually we do betadine painting and all, then we start the SFJ flush ligation where we do two fingers breadth niche. Then I was about to put the cautery, suddenly the sister or someone had put the sterilium over there. And when I put the cautery, immediately it caught fire. After 10 minutes of the spirit, it caught fire and it was completely, the thigh was little bit, it was burning. So I immediately put the cloths and everyone, and then it spread into that back. So he had this much big, almost 7 to 8% burns over the back. So at that time I had to struggle for the patient to explain that this is unrelated complications, but it happened because of the short circuit or something, because we cannot blame the hospital as well in front of them. Otherwise they will also sue it sometimes. So it managed somehow, and we told that we have to do free dressings for almost up to it is healed. So that what we committed, and we told that no, we should not take any OPD fees from him. Whenever he comes, he can come for 6 months free of cost.
Yeah, this can happen to anybody.
Yes.
But to tell all audience that
Yeah, complications,
buttocks-
no? So-
Yeah, complications hote hain and you need to manage. Hand holding, if you do it, most of the Indian patients are still, they are knowing that doctor's intention was good. And to tell this, when you talked about this, buttocks is very bad site for cautery putting patient plate. As there is so much fat, you should put on the same side where muscle mass is there and your contact will be good. And try to avoid your heart even in between. So buttocks is very bad site for any cautery plate putting.
Next question. Yes, sir, definitely.
This regarding complication, this is the most important thing is once it is a normal, anytime any can happen with complication in any surgeon's hand. But once there is a complication, treat that patient as a VIP patient. This is the first thing. Give all topmost priority with compassion. Even if it is possible, do all free of services.
And even if complication just starts, and let the patient know that there is a complication, because you might not knowing. No concealing of the fact. That is most important also. And what are the options available? What I am going to do for the next step? How to manage this complication? Everything you have to discuss with the patient.
Yeah, definitely.
And keep patient and, as madam said, a relative which is who is in his journey. To keep main patient and he's one of the known relative in his journey. So don't hide any dressing or call patient's relative that this was the wound, now it's improving. Let them take photograph. Court says your reasonable care. Court doesn't say that your utmost best care. Any reasonable care, though complication hand opens in any hand. So courts will say if it is a complication, have you treated it as normal doctor will treat? It does not treat like Raheja or Hinduja. We treat as normal doctor. What normal doctor will do? Have you done it? And document it. If you have done it and not documented it, it is also of no use. Okay. And sir said very rightly, keep that patient as VIP. If you are not doing burns dressing and your dresser is doing, for that patient, you need to do it.
So next question to Sunil sir. So what are the medical legal consequences of accidentally sharing a patient's identity online? So how should sensitive patient data should be stored to meet the legal standards?
Sorry, can you read it again?
What are the medical legal consequences of accidentally sharing a patient's identity online?
Patient's identity sharing. Accidentally.
Accidentally,
Made
not
accidentally.
knowingly, accidentally.
See, first of all, as Dr. Astos already emphasized in his lecture also, we have to, along with the consent and documentation, we have to take utmost care the privacy of the patient should not be leaked, should be maintained. Okay. With utmost care taken by us, and it should be explained to the patient also. Like when we are taking a photograph of a face, or for a gynecomastia we are taking the photograph, we are not taking the face. And after taking the pictures, suppose 5 pictures I took, I show the patient the photographs. See, I took these pictures, and nowhere your face is seen. Okay, so like that, I'm just quoting on one example. Same way, you can take the measures that the privacy should be preserved and should not be leaked. And despite that, and the patient should be aware of that we are taking utmost care not to breach the privacy of him or her. After that, if it gets into somehow it is leaked, then we have to explain the patient honestly that you see, I have taken all the care that your privacy should not be breached, but somehow it has happened. So then we can take the help of like cyber crime, जो police department का जो cyber security or something that we can intimate that the further spread, we can take the effort that the further spread of this privacy should be checked. I don't think beyond that we can do anything.
I think we can tell that our account is
Actually,
hacked.
Nowadays, all the patients want their surgical photographs. So I tell them that if I send you on my own on email, it will be my responsibility. But I would like you to write to me to send your photographs to you. After that, if there is any leakage, then it is not my responsibility. So I make them write a mail to me, ki please share my pictures. I share the album link. I write that I'll keep it open for 7 days. Till then, please download your photographs. After that, the link will be closed. And I close it after 7 days. No, 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 no. Email is the official channel that is acceptable, and basically WhatsApp is end-to-end encrypted. So nobody can, even courts cannot force WhatsApp to give them the data to find out who did it. So email is the most, and no, I refuse to send on WhatsApp. And in fact, many patients want to see our results on WhatsApp. That also I refuse to send. I tell them how you will feel if I send your photos to my prospective patients. So you come to the clinic. Their own also I don't send. Because WhatsApp, the screenshots are there. You never know. And the actions are very quick. So
Can you just elaborate about the photograph consent? There are one is you have to take consent, whether you will show it in academic session or not, whether you will share it with other patient for clinical purpose. Just can you just elaborate? What should be the consent for photographs?
actually, just go to IAAPS website. There is a tab called IAAPS consents. And if you open general consents, there is a consent for photography. There is a separate consent for videography. So you can just print the same. And now it is become a system, so I will not remember offhand points now.
Actually, in that you have 3-4 options also, like photograph only for documentation, photograph for internet website, photograph for publication, whatever patient takes out, you can use it for that. And talking about the question of, what was that? Accidental leak of, yes. So most of the time what happens is, if patient sees his photograph somewhere, he directly tell it to you. And usually it is not accidental. Usually it is intentional that we need to put our result on website or on YouTube. So when they inform us, if it is on our channel, then we can immediately, without any argument, you need to remove it out. That's the best thing. And if it is a leak on social media by some staff, that I had one case that one patient has accident on the lower part and perineum, and that OT staff took the photograph, and he said that there was a mobile in his pocket and it burst out and caused this type of injury. So my friend from Bangalore phoned me, that was this type of incidents that happened. So don't allow any staff to take photographs for you. That is also important.
Actually, this is the last point of what Dr. Sar mentioned, that this is a normal circumstance in most of the theaters, that any other staffs, the support staffs, medical staffs, they used to keep taking photographs of the interesting cases. So there we need to restrict them, that no, the photograph will be taken only in my mobile or my camera.
Instead of mobile, you should use the camera. That's the best thing.
Even I would like to share one incident, my personal experience. 13 years back, I had been a fellow in New York University with Dr. McCarthy. I requested him to have a photograph in his theater with him. He said, no, it's patient privacy. We can't have photographs here. Even the patient was draped, and he was in scrub. I was in scrub. And incidentally, he invited me to their conference room, and there he called me to, doctor, please come. You wanted a photograph with me. So that strict they were, because in US they are very strict about the patient privacy. So, madam.
Certain religions have restriction about taking photographs. So I had recent experience about one abdominoplasty with hernia, in whom I was thinking that there might be complication. So I told her that I have to have photos, and as soon as your 1 month is over, they will be deleted. So such religious things also you have to follow.
And one time, one patient, if he or she is not allowing you to take photo, means there is something fishy in that patient. Leave the operation theater, leave that patient. If the patient is right, if you are hiding the identity and still he or she is not allowing you to take photo, be aware of that type of patients.
Well, I have my experience of 3 decades and working most in a public hospital, also in nursing homes. There is a protocol in Stanley Hospital. Professor Venkat Swami, he never allows anybody to take a snap of any patient. He used to put 2 gloves. The outer gloves, he takes his own snaps of the patient, maybe pre, intra, and also post. And he throws up the second gloves, and the other gloves he operates. So what I mean to say, that should be a protocol inside the OR that everybody, like today, no, everybody takes a snap of the patient. That should be restricted, that should be some protocol. That is very, very important. Number 2 is 4 people are dangerous for physicians. The 3 P's are the police, press, and pleader. Pleader means advocates. When they have a connection with the patient somewhere, they put a problem. Press is always ready if there is a death or problem, complication. So these people has to be tamed. So in my 3 years in a government setup also, there have been complications, problems. But it was all managed because preventively you have to put these people somehow into proper order in your way, not their way. Once it comes in the media, I remember one patient, it came the media headline front paper. The doctor operated in a CV so and died. And he died of this. But the patient in fact died of a anesthesia complication, not for a surgical complication. But the whole everything comes to the surgeon. That is the biggest problem in any setup, private or government. And police is always ready to make double role, so the attendant, they attack the doctor. So that principle is by A, B, C, D. Your availability as a senior surgeon, if you have done some complication arised on the table, or you should be available. A for A, available. Second, B for behavior. You should be very polite and docile before the attendants others. And third is, if you do not have a lunch that day, please skip it. So that the patient attendant think the doctor is so concerned about my patient's recovery. So many cases, I think Dr. Giri is also there, residents and the whole team should be more alert of the patient and always isolate the patient from general ward and others. He should be given so-called, somebody has told, a VIP treatment. And all possible investigations, ECG, all that what is needed has to be on the patient. And madam has already told, please spend some money from your own pocket if it is required. I remember one patient who had to shift to the ICU, paying money to the ambulance, private ambulance, government ambulance are not available. So when next day money patient expired, the attendant is telling, sir, you have not taken your lunch, whole night you have been there and you have paid money, we have been in track of you, what you are doing. So A, B, C I have told, this C is for your competency. Put involve 3, 4 other people, anesthetists, other people, physicians, so that patient attendant think that everything is been done. D is do not demand any money from the patient after the complications. So A, B, C, D and 3 P's what I mentioned, and most dangerous for any doctor is the press. Negative means they have a hot cake. So please manage them, and if something goes wrong also they have done, next day morning what I did in some case, I put up a counter to that this is not the fact, fact is this. So all these things are required if you want to really shape in your any surgery. Complications is nobody's game, it can happen to anybody.
Okay. So next, this is the last question to the panel. What medico-legal consideration arise when treating medical tourist patients? Patients coming from foreign nationals.
I think, Madam.
Medical
So
tourists.
basically language is a problem. Usually they come here to save money, so they cannot stay long enough. They cannot bring accompanying person. So these are the problems. Plus you have to follow certain formalities. They have to be on medical visa. They cannot come just on tourist visa, get operated and go, unless probably they are NRI. Then you also have to inform the FRRO, that is Foreign Visitors Office in your place, when they came and when they went. And they may hide many things. When in a corporate hospital where I was operating, there was a liposuction done by another surgeon. The patient was a single mother. She kept the children in USA, came here on the night. She was investigated well overnight, operated next day. And fourth day she was found dead because of pulmonary embolism. And there was a huge issue because there was nobody to report to, there was no witness, there was nothing. So it went to a very high political level, embassy level issue.
At least one attendant. What is the rule actually? You should have one patient's attendant always, then operate, or you can operate with only patient's consent? No, for our patient also, if same thing happens.
Our patient, I always prefer to have attendant, but it is not compulsory. But this is my experience. Even I have had gynecomastia patients who came on the day of operation, only mother came directly. I had explained everything to the boy. But mother started crying, why you are operating on my son, what if he dies? You know, such things can happen and that will really ruin your peace. So I try my best to insist and have one attendant. About foreign patient, I am really not sure because whether that foreign patient trusts the attendants he catches hold of, should you choose for that person, then you become responsible. I am not sure. There is no clear rule for that.
So for NRI patient, as Madam suggested, medical visa is must. You cannot operate them on tourist visa except in emergency. All cosmetic surgeries are planned surgeries. We all do it. But the catch here is, in your indoor case paper, write the address of India. Patient, we in history write an alleged history of. So patient has given history and residence of this. If most of the time NRIs have two Aadhaar cards, means here they are also the citizens and there also. So they must have Aadhaar card also. Some ID that proves that they are Indian. Then you can do it on tourist visa. Otherwise, medical visa is must. Medical visa, to get medical visa is very easy. Government has put online, you just do it. They may require your letter. You can send a letter that this is required. And best thing is to do it under medical visa. Attendance number, what I suggested in my lecture, is must even for foreign patients if they are coming alone. Don't operate patients from Pakistan, Bangladesh, whatever countries we are in problem, and those who are attached to terrorism. Leave that patient. If you are operating on any single foreign national, you need to inform your nearest police station also that I am operating this patient. They don't care. I have so many times informed, मुझे क्यों बता रहे हो sir? But you need to inform and take constable sign that we have informed police station. And specifically if you are operating on this country's patient.
Yeah, actually yesterday Dr. Vijay Kumar was referring to this particular point, and soon he is going to put all these data with regards to the foreign nationals in our website in the APSI, and he says that the individual has to be sent back to the police and asked him to report himself. He has to voluntarily report to the police station, and from there only he has to come. It's not that we report, that's what he says. For the nationals of Pakistan, Bangladesh and some other countries, sensitive countries. So that is number one. Number two, he said that we should fill in what is called a Form C. Form C. So where all the details of the individual will be there. So all the questions will be answered in that particular form. So that's online, and it will be in direct contact with the government. So we all have to, the moment you are trying to take a foreign patient, you have to become a part of that. You have to take, it's almost like a membership. And once you have a patient, if you fill in that Form C, every detail of the individual will be there, and your responsibility comes to the minimum. So he said that he is going to put it in the website soon, the guidelines to treat the foreign patients.
And it's the problem in our branch only. If he has come for liver transplant, too many relatives will be there. It's only the cosmetic surgery where they come alone. And even they need to hide. So that's the problem. So be aware of that mindset of the patient.
So thank you very much for an insightful discussion.
I want to add one more to the first question. That question was, what to do in case of complications. So if it is a very serious complication, or if it is a death on table, with indemnity policy, you must take medico-legal services also. There are companies which give with indemnity policy medico-legal services. You send on WhatsApp or email your documentation, they will check the documentation, everything will be done. After that, you change your case paper inside and then declare the death. So this is very much important in case of on-table death. So be aware that not only indemnity policy comes when court orders the amount, but medico-legal services will save you from going to the court.
So thank you very much. I would like to request Medha ma'am to announce the last prize of the after session, and the lucky draw will be taken out by Medha ma'am. So I would request Medha ma'am to withdraw the lucky fellow chit.
Withdraw or draw?
Aptos people, are you ready with the gift? There are no people. And
So
thank you,
nobody
Vikram sir.
wants it? Nobody wants the gift? It is Dr. Neha Sharma. Who's that?
Please come on stage.
Wow. Come.
Gift.
Congratulations, Nichu.
So you may direct you on stage.
Yeah. Can you introduce?
Yes, yes.
Dr. Neha Sharma, MCH second year, some hospital. Jammu, sir. Jammu Kashmir, Jammu.
So congratulations, Neha, and we want to attend another Aptos workshop in Jammu now. I think that you should do, no? You should hold the Aptos workshop in the state where the prize has gone. So that is how it will circulate and then eliminate. Yes. Yes, and I think Jammu is a place where the skin is European type and it is very utilizable. Yes, correct. Yes.
And I would like to request Medha ma'am also to inspire our youngsters who are practicing out there and also the newcomers who are into the plastic surgery field. So to say a few words and encourage them how to do or start a aesthetic clinic or how to do their grade and level, upskill their practice.
See, basically, we have all chosen medicine, and we have to accept the way it is. We have to accept the disruptions. We have to keep updating yourself. We should never be stagnant. At least in the early years of practice, the financial difficulties are really difficult to handle, pressures from all the sides, but still never give up on ethics. So when your foundation is strong in training and in ethics, you can build a good tower of success. It is very important to build a good foundation. Don't compare yourself with your engineer friends who are in US. US has also become shaky and difficult place now. So things are in constant flux, that you should remember, and it is only the foundation of ethics, knowledge and continuous updating that is going to help you survive the life. Thank you.
Don't mind, just communicate. Just I am telling Madam has already, there are 3 methods to get money: beg, borrow or steal. I think steal is difficult. Everybody cannot do that. But begging is also not easy. But borrowing, those who are not married, I think residents, they can have some dowries that I want these 10 lakhs, 20 lakhs of dowry in form of material of instruments and equipments. That can be one. Or you lend from the bank. And this is a good investment than fixed deposits or mutual funds. Now if you invest 20 lakhs now, you will get 20 crores in the long way. So I think purchasing own instruments, equipments has a lot of help in the young time. We realized later on, but it was not too late for us. But I think the young surgeons should not hesitate to purchase newer instrument and equipment which are possible, and that can be utilized by you.
I have one suggestion also for all newcomers. Start making your YouTube and Insta from day one of your residency. So when you come out of your residency, your channels are in flow. The other thing, start investing from your own stipend. Do mutual fund, do investment from the very first day. So you can take 60% of your investment as loan. And the interest rate on mutual fund, if you have invested 1 lakh, you will get 60,000 as loan. And the interest rate is 9%. You are anyway earning 15% in mutual fund. So even after paying EMI, you will be earning by 6%. So start from day one, investment.
Attention everyone. So coming to the last part of this, to bid goodbye to each and everyone, we'd like to thank our chief sponsor, Chadda Surgicals, and our mega sponsor, Glenmark, and all other products which we are using. And we have visited the stalls. Thank you very much for your valuable and insightful considerations as well as your inputs for our people. And thank you faculties and chairpersons for chairing a very nice session, and today as well as yesterday, and the workshop was conducted very well at AIIMS as well. And I would like to thank our APRASO team, APRASO, and to our seniors, to our colleagues and our juniors. And we are nice to see the young enthusiasm of the energetic and young and dynamic people from AIIMS, from SCB, from MKCG, and all around the outside state people from Kolkata, from Gujarat, from Kerala, Karnataka, many states. So we are really thankful to you people, and thanks to all the winners also for the quiz and the APTOS session. Thank you everyone. With folded hands, I request if there is some mistakes, or you can pardon us. So we will be trying to better ourselves in the next conference. Thank you everyone.